Welcome everyone for the class on respiratory system. So we'll be seeing various obstructive diseases and restrictive diseases as well as venous thrombus embolism in this class, what we're looking out for. First, looking at the obstructive and restrictive disorders, how do you actually differentiate it? How can pulmonologists differentiate it? What they do is they'll measure two parameters, that is forced expiratory volume and forced vital capacity. Forced expiratory volume is basically you'll ask the patient to take a deep breath and expire out forcefully. And how much air he has expired out over and second is known as forced expiratory volume over and second time. FVC is forced vital capacity. That is basically you'll ask the patient to take a deep breath. Once he has taken the deep breath, the air inside the lungs is known as forced vital capacity. When you divide an FEV1 by FVC, you usually get 80%. Basically, it means that you can expire out in 1 second 80% of the lung volume what you're having. That is the vital capacity what you're having. This ratio will reduce in obstructive airway disease. This ratio might remain in the normal range or even go on the higher side in a restrictive airway disease. Because in a restrictive airway disease, forced expiratory volume over and second and forced vital capacity both decreases equally. So the ratio most of the time remains in the normal range or might go on the higher range. Obstructive airway diseases, forced expiratory volume over a second decreases much more compared to that of the forced vital capacity. That's why the overall ratio will be on the lower side. This the differentiating factor usually is done by the pulmonologist rather than in the emergency department. What I want you to remember is in the obstructive airway disease, there is an obstruction for the air entry. So there is an obstruction, sorry, there is no obstruction for the air entry. Only for the air exit, there is an obstruction. In a restrictive disorder, there is a restriction for the entry of the air itself. That's the differentiating factor, what you need to remember. As in obstructive airway disease, there is no restriction for entry of the air, only for the exit. Air can get trapped inside your lungs. This is known as dynamic hyperinflation, which we have already dealt with it in the resuscitation chapter. So the first obstructive airway disease, what we are looking out for is the asthma. Asthma in adult, followed by asthma in children, so that we can compare each other and we learn. We are not learning about how to diagnose an asthma. What is the chronic treatment of an asthma? What we are trying to do here is someone who is already diagnosed with the asthma comes with worsening of the symptoms of an asthma, how to manage this patient in the emergency department. The first thing what is expected of you, according to the BTS guidelines, is to classify the severity of the asthma. How severe is the asthma now? Is it moderately bad, or is it acute, or is it life-threatening, or is it almost near fatal asthma what this patient is having? What will help you to differentiate between these four classes? One of the important factors you need to measure is peak expiratory flow. If the peak expiratory flow is more than 50% of the predicted value or the best for that patient, then it is a moderate. If it is between 33 to 50%, then it is acute severe. If it is less than 33%, then it is life-threatening. PEF will not help you in near fatal asthma. Next thing what you need to look out for is the other symptoms what you will see in acute severe asthma. You will see tachycardia and tachypnea. And he'll not be able to complete a sentence in a single breath. That is very important. If you talk to him, he'll take breaths in between. He'll like, my name is John. So in a single breath, he was not able to complete a complete sentence. That is important what you need to pick it up from the stem of the question. These features are absent in moderate acute asthma. What are the additional things you'll be seeing in life-threatening asthma? The patient would have exhausted. So all his accessory muscles would have been exhausted. Because of exhaustion, the carbon dioxide gets retained. So cyanosis you'll be seeing. There will be no chest air entry into the chest at all. It would have become silent because his respiratory efforts are almost gone, or it is nil. It is very poor respiratory efforts what you are seeing. Along with it, cardiovascular system also gets affected because of the hypoxia. Hypoxia-induced arrhythmias this patient can have that might result in hypotension. Carbon dioxide retention can result, but most of the time it is hypoxic brain injury or hypoxic encephalopathy leading to altered conscious level what we'll be having. Near fatal asthma, the main important thing what you need to remember is raised PaCO2 levels. because asthma is an type 1 respiratory failure, not type 2. In type 2 respiratory failure, we see retention of carbon dioxide. If there is a retention of carbon dioxide in an asthma, which is supposed to be a type 1 respiratory failure, then you need to think this patient will arrest at any point of time. I'm talking about cardiac arrest. Initially, it will be a respiratory arrest followed by a cardiac arrest. So at this point of time, you need to start thinking this patient might require an intubation to be done for this patient. That is the importance of picking up and raised PaCO2 values. Next thing what you will be looking out for is the next thing what you will be looking out for this is the respiratory rate. What you can see here is in acute to severe asthma, only in acute severe asthma, not in moderate acute asthma, the respiratory rate will be on the higher side. That means the patient is hyperventilating. Whenever the patient hyperventilates, he will wash out carbon dioxide. So low PaCO2 is what expected in an acute severe asthma. In a life-threatening asthma, the PaCO2 values will be in the normal range. Why? In spite of having a high respiratory rate, due to the poor muscular actions or the poor chest expansion, there is not enough carbon dioxide exchange, or is not expiring out enough air to wash out the carbon dioxide. That will result in certain amount of carbon dioxide retention. That's why the PaCO2 values, rather than being on the lower side, it comes to a normal range. Still worse condition of this is raised PaCO2, what you see here in near fatal asthma. That is the importance of PaCO2, what you need to look out for. Another takeaway point is, for example, the patient has a tachypnea, tachycardia, and his SpO2 values are less than 92. That is enough for you to label it is a life-threatening asthma. That means any one of this feature, for example, he has all the features of acute severe asthma, but one feature of a life-threatening asthma like an hypertension, or in PaO2 values less than 8 kilopascals. That is enough for you to label as in life-threatening asthma. For that matter, the patient might be exhausted, having a SpO2 values of less than 92, PaO2 values of less than 8 kilopascals, but there is a raised carbon dioxide level, arterial carbon dioxide level. That is enough for you to label a near fatal asthma. So any one feature which is present from an more severe form of asthma, that is enough to call it as a much severe asthma. So remember this point. We are learning adult and child side by side because there are very few changes which can easily be known. So in moderate acute asthma, the patient is able to talk in single sentence. It is same that of the adults, no changes. SpO2 values will be more than 92. Same as the adults, no changes. PF value will be more than 50%. Again, same thing. There is no tachycardia, there is no tachypnea. Same thing in acute severe asthma, there is tachycardia and tachypnea. The difference here is the normal range for the heart rate and the normal range for the respiratory rate changes from age to age. What do you need to remember? Adults, you can give a fixed value. Here, it changes from age to age. That's the difference. But the PEF value remains between 33 to 50%. The change here is SpO2, you need to remember, falls less than 92 in acute severe asthma itself. Here, it is in the life-threatening asthma where you see the oxygen saturations falling down less than 92%. Here in acute severe asthma itself, it will start falling down. This is the main important differentiating factor what you need to remember. Next thing is in life-threatening asthma, everything remains kind of same, nothing changes. There is no near fatal asthma in an pediatric age group. That class doesn't exist at all. Okay, remember this point. Remember this point. Those are the two important differentiating factors what you need to remember. So we are not, basically, we're not dependent on PaCO2 values at all. No way we have mentioned about PaCO2 values for that particular reason. Chest X-ray. Usually chest X-ray is not recommended to get it done in an asthmatic patient. You will get a chest X-ray done only if you're suspecting an air in the pleural space, air in the mediastinum, or you're suspecting a pneumonia, that is consolidation is present, or it is a very severe form of asthma the patient has presented with, that is life-threatening asthma or near fatal asthma. You will go ahead and get an X-ray done. What are the other indications? Other indication is failure to respond to the satisfactory treatment. Or basically, you're given the treatment and you're not satisfied with the response what you're having. The treatment, you wait for 1 hour after giving the treatment. Then you say, I do not have a satisfactory response. At that point of time, you will go ahead and see and get an X-ray done to basically see if anything is wrong and anything you're missing it. If the asthma is so severe, requires an ventilation, that is, we are talking about near fatal asthma, then also you will go ahead and get an X-ray done. This is a similar point what you are having here. Again, pneumothorax, we have dealt it in major trauma class. So easy to pick it up. Here, completely collapsed lungs, what you are having, low lung, no bronchovascular markings, what you can see up to the chest wall, completely black, what you are seeing here, clearly suggestive of an pneumothorax. When to get an ABG done? ABG is arterial blood gas done. Arterial blood gas, the procedure itself is a quite painful procedure. So it is not recommended to get an ABG done for every patient who presents with an worsening of the asthma. You get it done for every patient who has low saturations in an asthmatic patient. Low saturations means less than 92%. We tend to try and get in every possible patient a peak expiratory flow rate. What we do is we'll ask the patient to take a deep breath and expire out through this mouth face what we are having. He'll make a good seal around this mouth face and expire it out. So he's pushing the air inside this. This will push the piston up and give a reading. Usually it will be around somewhere between 400 to 450, the normal range, but it depends on patient to patient, the predicted value or the best value the patient might be aware of. This device might not be practically possible to use it in a severe form of asthma, like in life-threatening asthma someone is having who is very breathless. If you ask him to take a deep breath and blow this, he may not cooperate. And again, in a pediatric age group who is around like 6, 7 years old, might not cooperate. So you will try to get it. If he's not cooperating, then you'll not force him. Now coming to the treatment per se. The treatment, there are two things. One is nebulization, or you're giving puff, basically directly delivering the drug to the lungs. Okay. The another form is giving an intravenous drugs. These are the two mainstays what you are having, followed by the steroids. Steroids are given for anyone who comes with worsening of the asthma. Okay, any acute exacerbation of asthma, doesn't matter it is a moderate or severe, acute, severe or life-threatening, they get an steroid. That's what you need to remember. Coming to the nebulization, initially in a moderate acute severe asthma, usually we go ahead and give some puffs. Ask them to take around 4 puffs, then add up another two. In acute or life-threatening asthma, we'll change the route or change the delivery device to the nebulization. Nebulization, the preferred one nebulization, what you give is salbutamol, which is an beta-2 agonist. The dose is 5 mg. You can give back-to-back doses if the patient is not responding. There is no upper limit. Ipratropium bromide is an anticholinergic. It also causes an bronchodilation. The dose what you're giving is a 0.5 mg, or you can remember it as 500 max, one and the same. But you cannot give this drug back to back. You need to wait at least 4 hours before you get a second dose. So most of the time, the second dose is not given in the emergency department because you need to wait for 4 hours. By that time, you would have admitted this patient. There is no role of nebulizing and calcium sulfate. Remember this, in adults, there is no role of giving an calcium sulfate. Steroids, everyone gets in steroids. You giving an intravenous steroids or you giving an oral steroids, doesn't matter. Both have the same efficacy, both have the same effects. So usually we prefer giving prednisone. If he is able to take it orally, then give it orally. If he's not able to take it orally because it is a near fatal asthma, you're planning to intubate the patient, then you might have to give it intravenously like hydrocortisone, or much better is methylprednisone because it has much better penetration in the lungs. You can give it. Usually we prescribe minimum of 5 days or until he's completely recovered or he's got back to his baseline. You are given two nebulizers here. That is salbutamol. You are given added ipratropium bromide because it didn't respond to the salbutamol. So you added ipratropium bromide, still not responding. What you do? You go ahead with intravenous drugs. The preferred way intravenous or the first line intravenous drug is magnesium sulfate. You 2 grams infusion over 20 minutes. Still not responding. Then you start on aminophylline. Usually we need a senior medical staff advice, that is basically just consultant physician's advice before we start it. What about antibiotics? Antibiotics is not routinely advised at all because most of the time asthma is not worsening of the asthma is not because of an infection. It's very rarely because of an infection. You are strongly suspecting or you have an clinical evidence that this is because of an infection, there is worsening of the asthma. For example, on a chest x-ray, you have a consolidation. At that point of time, you can obviously give the antibiotics. No, you are just suspecting an acute exacerbation of asthma because it is an winter season or because he had gone to a trip to a place where pollen rains are more and it got acute exacerbation of asthma. Then you do not prescribe it because infection is not the triggering agent there. Remember, again, we have covered this in anesthesia chapter. N9 is not recommended in asthma patient. Do not use it. If it is severe enough, cannot maintain the saturations, then you directly go ahead for intubation rather than starting on an NIV. What about in the pediatric age group? Very much similar with only minimal changes. What you need to remember. Again, we give beta 2 agonist, that is salbutamol here. Preferred way of delivering this drug is by using an inhaler and the spacer and using a mask. So inhaler is connected to an spacer, which is in turn connected to an mask. And you will make sure the good seal is there. And once you are given one puff, then you'll ask the patient to breathe through it in and out for approximately 10 breaths. This is the best way to deliver the drug. If the patient is cooperative enough, most of the time they'll be cooperative enough, kid will start feeling better. So this is the better way. If you connect to the nebulizer, he'll not keep the mask for a long time and the drug will not get delivered adequately. So this is the preferred way to deliver in the pediatric age group. Unless and until it is a very severe form, the patient is not cooperating, then you can go for nebulization. Ipratropium bromide, you will add up if the patient is not responding. Additional thing in the nebulization is magnesium sulfate you can give. So the first line of drug is salbutamol, nebulizer, or you are giving through an spacer. Preferred one is spacer. Next one is ipratropium bromide, again nebulizer or with a spacer. Third one is again a nebulizer, that is magnesium sulfate, which is not given in adult. You're giving here. This is the change what you need to remember. Prednisone, oral prednisone, like in adults, everyone gets it here, minimum of 5 days or till the patient gets recovered. They are not responding to the nebulizer. What you do, then you start on IV drugs. The first line of IV drug is magnesium sulfate. The second line of the second line of IV drug is IV salbutamol. The third line is aminophylline. Before you start an aminophylline, you need to have an senior medical advice, similar to that of the adult. Also, in adult also, we said the same thing. Same thing holds good for the pediatric age group. So two drugs adds up here in the pediatric age group. One in the nebulization, that is magnesium sulfate. As a nebulizer, you get it. So if this two nebulizers doesn't work, you start with the third one, that is magnesium sulfate. Again, beta 2 agonist salbutamol can be given back to back. Ipratropium bromide can be given only 4 hourly. Magnesium sulfate, only one dose you can give it. Everyone gets an steroid. First line of IV drug is magnesium sulfate. Second line of IV drug is salbutamol. Aminophylline, we usually need an senior consultant's advice before you start giving it intravenously. Same thing what we learned for the adults also. When do we admit the patient? Anyone at the presentation itself was an near fatal or an life-threatening asthma, quite severe presentation is there, then obviously you will be admitting the patient. Anyone has an acute severe asthma after giving an initial treatment. For example, he presented with near fatal or basically acute severe asthma only he presented. He given the treatment, but still acute severe asthma symptoms are present, like an tachycardia or an tachypnea is still persistent in spite of the treatment. Then you'll go ahead and admit. When do you think the patient requires an intensive care? Intensive care is required, obviously, when the ventilator support is there. For example, in a near fatal asthma, usually you'll intubate the patient. That's why ventilator support is required. With an acute, severe, or life-threatening asthma who is failing to respond to the treatment. In spite of giving treatment, he's still in the life-threatening asthma itself is not improving at all. Then you might have to think he might require an ventilatory support. That's why he needs an ICU care. When can you discharge in an adult? So the discharge criteria for an adult and a child is slightly different. In an adult, you can discharge if the peak expiratory value is more than 75% either of the best or the predicted value. Okay, after 1 hour of initial treatment, then you can discharge them. Before you discharge, make sure they have enough inhalers available with them. Both the salbutamol and ipratropium bromide are available with them. And ask them to follow within 24 hours of discharge with the GP. This appointment usually is given by us itself. We fix an appointment with the GP or we write a letter to the GP saying that I've discharged this patient who had come with an acute exacerbation of asthma. Please review and see how is he improving. So for that reason, you need to inform him that within 24 hours, you need to meet up with the GP. This advice needs to be given both verbally as well as written. Child discharge. You're giving a child discharge when he's stable enough and requires only inhaler to be used, that is with the spacer, every 3 to 4 hours, not less than 3 hours. Usually we say not less than 4 hours itself. His peak expiratory value is more than 75% of the best or the predicted if you can measure it. And his saturations are within the normal range, that is more than 94%. You need to give this advice in written. It's a must. Do not forget. Make sure they have enough inhalers available. They'll follow up with the GP in the 2 days. Here it was 24 hours for the adults. Here it is 2 days. That's the differentiating factors you need to remember that in this way, differentiating between adult and pediatric help you to memorize better. You need to arrange an asthma clinic within a month's time. Okay, because this is a pediatric age group, whether and chronic management of the asthma needs to be changed or persist with the similar type of treatment, that call will be taken by a specialist. That is a pediatric asthma clinic. They need to go and have a visit and have a checkup done. So this appointment needs to be given within a month's time. This 2 days has been previously checked. That doesn't mean they'll not check about the adults. So you need to remember in next day, they might check about the adults, or the next day, they might check about the pediatric asthma clinic when the kid has to follow up with a pediatric asthma clinic after a month's time. Now we are going into chronic obstructive pulmonary disease. How does this patient, usually again, the patient is already diagnosed with a COPD. Short form is COPD for chronic obstructive pulmonary disease. They present with worsening of the symptoms. Worsening of symptoms, the main symptom most of the time is worsening of shortness of breath. Because he's breathless, because he's hypoxic, he will have some tachypnea. There might be a classical finding which is known as pursed lip breathing. They inhale through the nose, as shown here, inhale through the nose and breathe out through the mouth through the pursed lips. This is known as pursed lip breathing, classically seen in COPD. To be more precise, classically seen in emphysema. Okay, to more precise, it's a COPD. What you're seeing, what you need to remember, that is important. Accessory muscles, they'll start using it. So you have the accessory muscle, they are using it. And COPD is in type 2 respiratory failure. So they start retaining the carbon dioxide. So cyanosis can be seen, along with some amount of clubbing also can be seen. This can have pressure over the right ventricle over a longer time, resulting in right heart failure, resulting in pulmonary edema. And he might say that I'm not able to carry out his daily activities. Usually I used to able to stand and cook myself. Now I'm not even able to cook myself. Doctor, I'm not able to take care. This COPD has worsened. That's how they usually present. Or they might say, I'm just not able to breathe. It is not like unusual. It has worsened. Doctor, do something. That will be the two common presentation to the emergency department. Let us talk more about the pulmonary edema. What actually happens in pulmonary edema? In pulmonary edema, why pulmonary edema is developed? Sorry, why pedal edema is developed? Not pulmonary, sorry, pedal edema. Why pedal edema is developed? This is the lungs what we are having. Okay, COPD is an lung disorder basically. Over the time, the resistance in the lungs increases. Once the resistance in the lungs increases, the back pressure. So where with the back pressure, or from which part of the heart the blood gets pumped into the lungs? It is the right ventricle. From right ventricle, it is getting pumped. So back pressure here is the right ventricle cannot pump enough blood into the lungs because of the increased resistance. What will happen? That will cause retention of the blood inside the right ventricle, resulting in right ventricular failure. Right ventricular failure, again, back pressure. That's how you will have hepatomegaly, pedal edema, rash, JVP, signs and symptoms of right ventricular failure, what we'll be having. This whole thing together is known as cor pulmonale. And this takes around a decade's time, if not more, to develop enough resistance to have an right ventricular failure, resulting in a resulting in a pedal edema. So it takes in decades, if not more. Usually takes 10 to 15 years it takes to develop this. Doesn't happen in a newly diagnosed COPD patient. What are the investigations? We go ahead and get an X-ray done in all the patients who have presented with an acute exacerbation of COPD. Why? Because infection is the most commonest cause for acute exacerbation of COPD. That's why you go ahead and get a chest X-ray done. The classical features of chest X-ray in a COPD patient. You can see the heart is quite thin. This is known as tubular heart, what you're seeing. Diaphragms are kind of flattened here. And this doesn't look, or it more looks like a barrel shape. So barrel chest, you'll be having tubular heart, you'll be having flat and expanded, or the lung fields are quite large, expanded, what you're seeing, along with flattened diaphragm. These are the classical features what you'll be seeing. In an acute exacerbation, along with this classical feature, there might be a patch here suggestive of a pneumonia. Then you might have to go ahead and admit this patient and give IV antibiotics. Because these patients can cause hypoxia and can cause carbon dioxide retention, arrhythmias can be triggered. So get an ECG done. Full blood count, urea electrolytes, mainly for the pneumonia. If they are on theophylline, has a narrow therapeutic index. That's why you need to get an theophylline levels done. Theophylline is commonly used in an COPD patient. That's why get an theophylline levels done if they are on. If they're having an productive cough, having an yellowish color sputum, then get an sputum culture done. If the patient is having fever, add up blood cultures to them. How do you treat them? If the patient is hypoxic, obviously you'll supplement with an oxygen. Same thing holds good for the asthma patient also. Here, the saturations is recommended to be maintained around 88 to 92%, not more than 92%. The school of thought not to maintain more than 92% is hypoxia basically maintaining around 88 to 92%. There is enough hypoxia to trigger the respiratory centers to have an good respiration. If hypoxia is avoided, if the saturations are maintained more than 92%, the hypoxic drive will be lost. The respiratory centers will not be triggered. This is more theoretical. If you ask me, still it is under research. Still, we do not have enough evidence to say why we need to maintain between 88 to 92. But many clinical trials, if not all the clinical trials, have shown that maintaining the saturations between 88 to 92% is the best approach for a COPD patient. For that matter, for any type 2 respiratory failure patient, maintaining a saturation between 88 to 92% is the best approach. Then you start the bronchodilators, salbutamol and ipratropium, similar to the asthma, no changes. Steroids, you start with 30 mg. Here you give it for a longer time, 1 to 2 weeks, what you give it here. Antibiotics. Most of the patients, if not all the patients, gets antibiotics done. Okay, so most of the patients get an antibiotic done because the infection is the most common factor here for that reason. Theophylline. Remember this, people tend to forget here. Theophylline, if not responding to the nebulizers, what you're given. What nebulizers you are given? You're given salbutamol and ipratropium bromide. They're not responding to this nebulizer, then you add up an theophylline. This is an IV drug, what you're adding up, has a narrow therapeutic index, so close monitoring is required. So remember this parameter, do not forget, this is the IV drug. It is not magnesium sulfate what you're giving. Magnesium sulfate is only for the asthma. Theophylline is only for COPD patients. It's the only IV drug what you'll be using in an COPD patient. If you have used bronchodilators, not responding. Theophylline you have used, not responding. That's when you go ahead and think of an NIV. Is there an indication for an NIV? After giving a medical treatment and waiting for an hour's time, still persistently there are indications for an NIV, then you go ahead and start with an NIV. We already learned about the indications for an COPD according to the BTS guidelines when to start an NIV. Let's revise those indications. Here, the pH being less than 7.35 is one indication. PaCO2 values being more than 6.5 is another indication. Respiratory rate being more than 23 is another indication to start a patient on an NIV who is a known case of COPD. Physiotherapy most of the time will be requiring not responding to NIV also, then this patient might require an intubation, which is we try to prevent as much as possible because once you intubate, extubating this patient becomes almost impossible. That's why we tend to avoid it. If NIV is started, usually ITU is required. Remember that NIV, whenever you're starting, it generates aerosols. So you need to wear the PPE. Especially this is stressed more during the COVID time. What is the indication for admission? When do we admit? Do we admit all the patients? No, not required. Unless you have this kind of presentation. It's a rapid onset. Within a day's time, it has got worsened. Quite severe breathlessness is present where saturations is less than 88%. Okay. And there is enough carbon dioxide retention, which is causing altered sensorium. He's confused. He's disoriented. Significant comorbidities, that means associated comorbidities, like he might be having an IHT associated with it. Significant comorbidity, a liver failure, or nephrotoxic, it might be a CKD patient. Then you go ahead and admit. Social reasons is another more important factor what you need to remember. He's living alone. No one is there to take care of him. He's not able to cope himself. Confined to the bed, you go ahead and admit. Not coping was again tested in the exam. So social reasons also we admit. Doesn't mean you are medically fit. Go. I do not care what you do in the home. No, you should you should see the patient holistically in UK. For that reason, is there anyone to take care of you? You're going back home. If something goes wrong with your symptoms worsen, is there anyone to call the ambulance? No one is there. I leave alone. It's midnight. It's unsafe discharge. I shall admit you. That's how the social reasons needs to be reasoned it out, and you need to admit the patient. On examination, if cyanosis is present or there is worsening of the pedal edema is present, you will go ahead and admit. On investigation, pH, that is any acidosis is present. Hypoxia, that is severe hypoxia, we are talking about less than 7 kilopascals on an ABG. If present, then you are admitting. Any new changes on an X-ray which are present, COPD changes or chronic changes, along with, for example, there is a consolidation what you have picked up on in chest X-ray, then you go ahead and admit. At the same point of time, I'm telling you a high value of PaCO2 is not an indication to admit. A COPD patient, normally if you get an ABG done, his values might be on the higher side. PaCO2 values will be on the higher side, but the pH will be in the normal because kidneys would have compensated using the bicarb. Okay, let me repeat it. In a normal COPD patient, usually PaCO2 will be on the normal side. PaCO2 values will be on the higher side. The pH will be in the normal range because kidneys would have compensated. This is an chronic type 2 respiratory failure. I'll be talking more about this, but this is an chronic type 2 respiratory failure. So a PaCO2 value on the higher side is not an indication for admission. If the pH is on the lower side, then kidneys do not have enough time. That means basically it indicates that kidney didn't had enough time to retain the bicarbonates so that the pH goes back to the normal range. So a pH being on the lower side is indicative of an acute insult what has happened, which has resulted in retention of carbon dioxide. Okay, this is an indication to admit. That's the differentiating factor. Do not consider a PaCO2 value, consider only the pH. Now we are entering into the venous thromboembolism. Before I go, if someone has any questions, we will just skim through it. Is there a role of hydrocortisone in acute severe asthma? It depends. Are you able to give the patient orally prednisone? Then give it orally. Why do you want to give it intravenously and prick the patient? No, you're not able to give it orally because the asthma is quite severe. He's not able to swallow it. Then you can give intravenous form. Intravenous form, hydrocortisone can be been used, but latest preferred drug is using methylprednisone, which has better lung penetration compared to hydrocortisone. That's why it is preferred over hydrocortisone. If in the options only hydrocortisone is given and the patient is vomiting, give hydrocortisone because you cannot give oral prednisone. Not all COPD patients have a sputum. If they do not have a sputum, don't get a sputum culture done. If they have a sputum, then get a sputum culture done. Most of the time, they do present with an sputum. They do have an cough. Venous thromboembolism. Venous thromboembolism is a broad term. Basically, the two important things what we will be learning in VTE, which stands for venous thromboembolism. One is pulmonary emboli. The another one is DVT. First one, what we are seeing is a DVT, that is deep vein thrombosis. Whenever a patient presents or you are suspecting a DVT, what we do is we do a 2-level DVT well score that will suggest you what next to be done. So you need to remember this well score favorite to be tested in the exam, either this one or the PE well score. They are likely to test you in the exam. So there is no way you're going to the exam without learning the DVT well score. So DVT well score, 2-level DVT well score, what is precisely what you need to be aware of according to the NICE guidelines. Any active cancer, that means ongoing treatment within the last 6 months, they have taken any treatment or they are on palliative care, it is considered as an active cancer. Okay. Any immobilization of the extremities due to an paralysis or any weakness in the lower limbs or because of an pot what you are having, that is considered and gets 1 point. Everything gets 1 point except the last one here. Bedridden for 3 days or any significant surgeries have gone in last 3 months, that is 12 weeks. Localized tenderness along the distribution of the deep vein. Entire leg is swollen. And if you measure it, if the calf muscle is swollen more than 3 centimeters compared to the asymptomatic limb, pitting edema confined to that particular limb which is affected. Collateral superficial veins can be seen. There is a previously documented DVT which is present. All have 1 point each. If you're thinking and another diagnosis is most likely, for example, cellulitis is most likely, then minus 2 points what you're having. Then you add up the points what you're having. If the point total comes as 2, then DVT is likely. If the point total comes as 1 or 0 or -1 or -2, then DVT is unlikely. This is important for us to further investigate and see DVT is likely or DVT is unlikely. There are different points which are present here. But basically what you need to remember is any immobilization recently what you are having of the lower limbs, what you are having, or any important surgeries which you have undergone. Next thing is any previous DVT. So active cancer, immobilization, major surgeries, previous DVT. These are the 4 different points. Next, all these other points can be remembered with the pathophysiology of DVT itself. What is happening? What is happening in a DVT? DVT is deep vein thrombus. It's a major vein where there is a thrombus. If there is a thrombus, what will happen? The blood cannot pass through it, so it gets dilated. So you see dilated veins. Once this dilated, the other collateral veins, the blood starts moving in. So collateral veins gets dilated and you'll start seeing prominent collateral veins. Once the blood is stagnant for a longer time, what will happen? There will be increase in hydrostatic pressure. Increasing hydrostatic pressure will cause oozing of the plasma, resulting in edema, what you are having. So entire limb gets swollen. Along with calf muscles also get swollen over the time. Swelling is because of accumulation of the fluids. And this is the fluid what is accumulated. So you apply the pressure, there isn't pitting edema. So all can be remembered, rest of the features, by remembering the pathophysiology what you are having. This is another way to remember it. So DVT, when you are suspecting, how to investigate. This is what is given. This I have broken down. It causes a lot of confusion if I go through this algorithm. So I have made up my own algorithm. It is derived from the NICE guidelines what we are having from this one. So here, first one what we are seeing is DVT is likely. That means the score is more than 1. So well score, 2-level well score, you're done. The score is likely what you'll be doing. Directly, you will go ahead and get an proximal leg vein USG scan done, which is also known as Doppler scan of the lower limb, what you will be doing it. You need to get it done within 4 hours. For some reason, if you're not able to get it done within 4 hours, then what you will do is you will send for an D-dimer level, start him on an anticoagulant. Preferred one is direct oral anticoagulants, what you'll be starting, and try to get the scan done within 24 hours. If the scan comes as positive, you have the diagnosis, you'll start the treatment or continue the treatment if you already started here itself. The anticoagulant, if you have started, then you will continue the treatment. If the scan is negative, then you will be looking at the D-dimer test. If you got the D-dimer test done at this level itself. If you not got the D-dimer test level done, get the D-dimer level test done here. Because this is DVT is likely according to the well score. The scan itself will not rule out and clot when the DVT is likely. So if the D-dimer is positive, what you will do? You stop the anticoagulants, but you will ask him to come back after a week's time, that is after 6 to 8 days, to repeat the scan and see. Still it is negative, then you rule out the DVT. Now the D-dimer has come as negative, then stop and think of some other diagnosis. It is not an DVT. Coming to when the DVT is unlikely. So the score is 1 or 0, -1 or -2, what you're having. If that score is there, what you'll be doing? Get a D-dimer done within 4 hours. For some reason, you're not able to get the D-dimer done within 4 hours, then you will start the anticoagulants. Preferred one is direct oral anticoagulants and wait for the D-dimer results. If the D-dimer is negative, then stop the anticoagulants if you've started. Think of different diagnosis. You're ruled out and deep vein thrombus. If the D-dimer has come as positive, the next step is to get the lower limb scan done. That is getting a Doppler scan done or the ultrasound scan of the lower limb is the one and the same thing. Within 4 hours. This is the same thing what we discussed. This is the same thing what I'm repeating here. Within 4 hours, you are getting it done. If within 4 hours is not possible, try to get it within 24 hours and start him on anticoagulant. If the scan comes as a negative, then you rule out. If the scan comes as a positive, then you treat it as an DVT. Okay, it's simple. If you break down in 2 different algorithms where one is likely, another one is unlikely, it is easier. What you need to remember here is in likely case, the scan will not rule out an DVT. In an unlikely case, a scan will rule out an DVT. That's the differentiating factor, main differentiating factor what I have told. It is important to remember how to approach. This treatment I'm not discussing here because the treatment for PE and DVT is one and the same. What is PE? PE is pulmonary emboli. It is an acute condition. So the presentation will be acute. I have an acute breathlessness along with a chest pain, which is pleuritic kind of chest pain, along with some amount of blood on cough, what is present. Because I am short of breath, there's tachycardia, tachypnea, sometimes even mild fever might be present. Signs of an right heart failure, right ventricular failure can be present in this patient. So let us break down this and see what actually happens in pathophysiology of NPE. In NPE, there is a large clot in the pulmonary vasculature. Because of presence of this large clot, most of the time it might be here itself in the major artery itself, there is a large clot. There is a back pressure. Okay, acutely this clot has formed. Acutely there is a back pressure. What will happen? There is a lot of pressure in the right ventricle. If there is a lot of pressure in the right ventricle, it starts dilating to accumulate more blood. So RV dilatation is seen in an big saddle kind of clot. It is seen, not a small clot. This somewhere here in periphery, you have a small clot here. It will not cause an RV dilatation. A large clot usually causes hemodynamic instability. That is a systolic blood pressure less than 90 for us hemodynamic instability means in those conditions you see an RV dilatation. Again, further it will be an RA dilatation. If RA dilatation is there, back pressure, where it will go? To the neck vessels. One of the major neck vessels is jugular vein, what you're having. So JVP, jugular venous pressure will increase. That's why you see an increase in jugular venous pressure. Increased pressure in RV will cause RA and RV dilatation. RA and RV dilatation are the acute signs what you see on the echo. So remember this point. So if the patient is hemodynamically unstable, that means the systolic blood pressure is less than 90%, 90 millimeters of mercury. What you do, you cannot shift this patient out to get an CTPA done scan. At that point of time, you depend on the echo, get an echo scan done. If an echo is suggestive of an acute dilatation of RA and RV, is suggestive of an massive saddle kind of thrombus, you can go ahead and thrombolize the patient. So you get a patient with a pleuritic chest pain. Whenever I say in pleuritic chest pain, it is not a typical cardiac chest pain. And this pain usually varies with the respiration, varies with the movements. It is sharp kind of pain, what you're describing it. Might be an young fellow who comes with a pleuritic chest pain. You're thinking it might be a PE, it might not be a PE. Do I need to do an 2-well score? No, not actually required. You can do an PERC score. PERC score stands for PE rule out criteria. PE rule out criteria PERC score stands for. Where you'll be seeing the patient should be young, that is less than 50 years. There shouldn't be any tachycardia, there shouldn't be any hypoxia, no hemoptysis, that is blood in the cough. He or she is not on any estrogen use for any matter. Mainly, we are talking about OCP pills here, which has an estrogen. No surgeries have undergone or no hospitalization in last 4 weeks. No previous history of DVT or PE. No unilateral leg swelling. So all these criteria should satisfy. If all these criteria is satisfied, using PE rule out criteria, you can rule out the PE. It is a rule out criteria. You can rule out, no investigation is required. You can, according to this criteria, have ruled out the PE. You can mention in your notes and move ahead and think of some other diagnosis. If any one of these features are present, for example, the patient is tachycardic or slightly hypoxic, or previous history of an DVT is present. If one of those also not satisfied, then you need to do all the patient 2-level PE well score. In 2-level PE well score, it says any clinical signs and symptoms of DVT are present. Okay, any clinical signs and symptoms. Usually we talk about any leg swelling is there and palpation, pain over the palpation of the deep vein if present, it gets directly 3 points. An alternative diagnosis is less likely than PE. This is a difficult terminology used or difficult phrase used by a NICE which is causing confusion. I will turn it around and say PE is the most likely diagnosis. So most likely diagnosis is a PE, or in your differential diagnosis, PE is at the top. Most likely diagnosis is a PE. Then again, it gets 3 points. Tachycardia, heart rate more than 100, 1.5. Any embolization or any major surgeries in last 4 weeks, 1.5. Any previous history of DVT or PE, that is venous thromboembolism, 1.5. Any blood in the cough, then 1 point you will be getting. A malignancy, that is an active malignancy on treatment or on palliative care in last 6 months, gets another 1 point. You add up all this score. If it is points are more than 4, more than greater than 4, not 4, greater than 4, then you directly go ahead and get an CTPA done. If the point score is 4 or less, that means it can be 3.5, 3, any score, you go ahead and get an D-dimer done. So what we will be doing here? I just told you if the score is more than 4, then you will be immediately getting a CTPA done. If you're not able to get an immediately CTPA done because CT machine is not working or CT scan is busy, they have a lot of appointments going on, then you'll start on anticoagulants. That is direct oral anticoagulant is the preferred one. Then while waiting for the CTPA. Once CTPA is positive, treat it as an PE. No, CTPA couldn't be, sorry, CTPA, you got it done and it has come as negative. Then you'll be thinking, is this patient might be having a DVT? Yes, this patient is having a DVT, then start thinking of DVT, forget about the PE, it is only the DVT what the patient is having to it. No, DVT you are not suspecting in this patient. Stop the anticoagulants, think of some other diagnosis. PE is unlikely, then get an D-dimer done within the 4 hours. Same as DVT, what we talked about in PE also, we say within 4 hours. Within 4 hours, you're not able to get it done, then start therapeutic anticoagulants while waiting for the result. If D-dimer is positive, you get into this algorithm. Same thing, no changes. If D-dimer is negative, you rule out PE and think of some other diagnosis. So PE is unlikely. Stop the anticoagulants if you have started it and think of another diagnosis. Investigations, mainly the D-dimer and CTPA we are spoken about. ECG is important. ECG is important because especially in NPE, when there is a large thrombosis present, RV strain patterns can be seen. Classical ECG patterns can be seen. I'll be discussing. Echo, I have discussed with you. Tropi, mainly because if there is a massive PE is present, there will be RA-RV dilatation. When there is an RA and RV dilatation is there, myocardium gets touched. If the myocardium gets touched, they break down. Breakdown will cause increase in trop I. So one of the causes for the raised trop I is a massive PE. Coagulation profile, because if you are planning to thrombolize the patient, you need to know the coagulation profile findings. Basically, is the INR, what is the PT, APTT levels before you go ahead with the thrombolysis. The baseline you need to be aware of. What are the classical ECG findings? The most common ECG finding what you are seeing here is high heart rate. This is the most commonest finding what you are having. Most precise finding or highly suggestive of an PE is a pattern known as Q3T3S1. They simply write it as Q3T3 and S1 pattern. What does this mean? S1 means S wave is seen in lead 1. That's why they call it as an S1. What is S wave? S wave is after R wave. If anything which goes negatively is known as S wave. So this is the S wave what you are having. Then Q3. Q3 is the first negative deflection what you are having after a P wave. You can see the first negative deflection after the P wave can be appreciated here. This is known as Q3, which is seen in lead 3. That's why name has come as Q3. What is T3? Inverted T wave seen in lead 3. It is known as T3. So Q3, T3, S1 is the classical finding what you will see in NPE, but it is seen in only fraction of a patient. That to a very small fraction, around 10 to 15% of the patients only present with this classical feature. So you cannot depend on this. If present, then you are highly suspecting of an PE on this patient. Along with it, there might be some RV strain patterns like incomplete RBBB. Incomplete RBBB means RS R dash pattern you are seeing it, but there is no broad QRS complex what you are seeing. That is the incomplete RBBB what you are talking about here. How do you treat? A stable PE and a DVT treatment are one and the same. There is no differentiating factors. It might look a lot mentioned in this, but what I inform you, if you can remember that much, that is sufficient. Renal impairment. Renal impairment is there if it is significant. If GFR is less than 15 ml per minute, that means quite significant renal impairment is present. Then low molecular weight heparin is preferred. Otherwise, you are giving direct oral anticoagulants. These are direct oral anticoagulants. Preferred one is apixaban, rivaroxaban. It ends with ban. You need to remember. The two names what you need to remember is apixaban and rivaroxaban. If there is an active cancer, you again give still direct oral anticoagulants itself. If for some reason, if it is contraindicated, then only you are giving low molecular weight heparin. Antiphospholipid syndrome is present, then you're directly starting on low molecular weight heparin. Warfarin will start along with it. Once the INR is more than 2 for 2 consecutive readings, then you stop the low molecular weight heparin and continue with the warfarin. In a person who doesn't have any renal impairment, active cancer, antiphospholipid is the apixaban and rivaroxaban, that is direct oral anticoagulant is the preferred one. To put it in a simple manner, you start with direct oral anticoagulants for most of the patient, except when there is an severe renal failure is present. Okay, at that point of time, low molecular weight heparin you're starting, or any patient who is having an antiphospholipid syndrome, in that patient also you're starting with low molecular weight heparin. That's all you need to remember from this here. There is a combination of low molecular weight, low molecular weight heparin plus warfarin you started because you want to keep them on an oral tablet. Then you're starting low molecular weight heparin only and only when the INR is reached at least 2 and 2 consecutive ratings, it is more than 2. At that point of time, you'll stop the low molecular weight heparin and start on warfarin. It depends on trust to trust and hospitals to hospital, which kind of approach they wanted. But this is the classical approach recommended by NICE guideline. Considering catheter-directed thrombolytic therapy for people with an symptomatic ileofemoral DVT, in whom you will consider what is this? If this is a vein and this is a thrombus, what you're having, you pass an catheter here, and here right intra-articularly you will deliver the drug. This is known as catheter-directed thrombolytic therapy. It is given when there is a large thrombus in a large vein that is at the level of femur or above, that is ileofemoral. At that level, if it is there, then you are considering it. You're considering this when the patient is symptomatic for at least 14 days. His functional status is good. He's not a bedridden patient on a palliative care, what I meant. And life expectancy is at least more than 1 year. And there is a low risk for bleeding. Keeping all this in mind, then you consider for catheter-directed thrombolytic therapy in an DVT patient. How to approach unsuspected massive PE. So you have a large PE, how to do it. The problem here is whenever there is a large PE, you cannot get NCTPA done. You do an well score will be on the higher side. But can you shift him to get NCTPA done? You cannot get because he is hemodynamically unstable. Whenever the patient is hemodynamically unstable, you are not shifting him out of the resuscitation room to get NCTPA done. How to approach when you are having it? First, see whether this patient have any signs and symptoms of an DVT. Okay, any signs and symptoms of an DVT is present. If present, get an ultrasound scan done bedside. If you're diagnosed an DVT, then it is kind of an indirect evidence that this patient is having an PE. Okay, because this patient has a breathlessness, shortness of breath, and he has presented with, along with the hemoptysis, low saturations, low blood pressure, all will go in direction of a PE, along with the DVT is present, which is confirmed. That is enough for you to go ahead with thrombolysis. No, you do not have any signs and symptoms suggestive of an DVT. What you'll do, the next approach, get an echo scan done to see an RV dilatation. RV dilatation, basically what you're looking out for. Do not get a scan done. I've already told you here. Highly suspicious. By these two things, you're making it highly suspicious. Then you'll directly go ahead and deliver the thrombolytic. Do not delay it. Once you're suspecting, you start delivering it. Thrombolysis is contraindicated or doesn't work. For some reason, it is not working or it is contraindicated because the patient's INR is on the higher side or some reasons. Then you can think of a surgical embolectomy or catheter-directed thrombolysis. I've already explained what is catheter-directed thrombolysis. Surgical or mechanical thrombolectomy. Again, this is a clot which is present. They pass an catheter and mechanically drill it and break it into small pieces. And there will be a basket, collect these pieces and exit out. That is a mechanical thrombolectomy, what you're doing it. After doing an thrombolysis, then you start an infusion of an heparin. Okay, this is taken from Oxford Handbook of Emergency Medicine. So holds good, follow that. Venous thromboembolism in pregnancy. In pregnancy, having a DVT or PE is 10 times, that is 10 times, 10x more common than any normal individual if you compare it with. Low molecular weight heparin is the preferred one. So we have another one when we need to start a low molecular weight heparin. One is antiphospholipid syndrome, what we have, severe renal impairment. Another one is pregnancy. In pregnancy, you'll start on low molecular weight heparin rather than on direct oral anticoagulants. RCOG, that is Royal College of Obstetric and Gynecology, recommends that do not get an D-dimer done. Because we expect the D-dimer to be on the higher side, it might give falsely high values. That's why they are not recommending it. There is a trick which is involved here is basically, though the RCOG is not recommending it, most of the emergency physicians, what they will be doing is go ahead and get an D-dimer. We know that D-dimer might be on the higher side and give falsely high value, but it fits in the normal range. It kinds of helps you to think of some other diagnosis. For that reason, they go ahead and get it. But for all exam purpose, remember that you are not getting the D-dimer test done in a patient who is pregnant and you're suspecting DVT or PE. That's what you need to follow for the exam. You get an ultrasound scan done. That is the scan of choice if you're suspecting in DVT. If it is confirmed, continue with low molecular weight heparin. Okay. And low molecular weight heparin is a good. It doesn't affect the fetus because it doesn't cross the placenta at all. What about PE? What you'll do in the PE? Get a chest X-ray done and see whether this patient has some other pathology which is going on. Other than PE, can it be an pneumonia which is causing the pleuritic chest pain and hypoxia in this patient? Might be. Get a chest X-ray done to rule out other causes. Any Doppler scan, if any lower limb is swollen or anything is suggestive of an DVT, get an Doppler scan done of the lower limb. No, chest X-ray you have done, nothing is there. Lower limb scan you have done, nothing you have found, no clot is there. But strongly you're still suspecting NPE, what to do at this point of time. You have two options, ventricular perfusion scan, you can get it done. This stands for ventilation perfusion scan, VQ scan we call it, or you can get an CT pulmonary angio. How to choose between this? The choice is given to the patient. The choice is given to the pregnant woman who is present. She will take a call whether she wants an VQ scan or an CTPA. What you need to explain is, if you go ahead with an VQ scan, your fetus in childhood having a cancer is slightly on the higher side compared to that of the CTPA. If you get an CTPA done, you having an maternal breast cancer is slightly on the higher side than compared to an VQ scan. So basically CTPA, if you get it done, it is good for the fetus. VQ scan, if you get it done, it is good for the mom. The call will be taken by the mom, the patient who is there. She will take a call whether which scan she wants to go at. The option will be given after explaining the risk factors what are involved. Treatment is again low molecular weight heparin, what you are giving it. The dosing is according to the weight what we calculate for the low molecular weight heparin, and the weight what you're seeing is pre-pregnancy weight or early pregnancy weight what is present, what you need to calculate for. In cases of massive PE, what we need to do? Can we go ahead and thrombolyze? That is a question. Okay, it remains as a question because the guideline says multidisciplinary team should be involved. That means gynecologists should be involved, vascular surgeons should be involved. Then you need to involve, vascular surgeons needs to be involved, neonatologist needs to be involved, emergency physician needs to be involved, intensivist needs to be involved, and they will take a collective decision what next to be given. Most of the time, they end up choosing an intravenous heparin. If the blood pressure is even in the borderline, they will go ahead. Unless mother is about to die, they do not thrombolyze. This is for your practical purpose. For exam purpose, it's a multidisciplinary approach. What do you need to remember? I'll just go ahead. If there are any questions, then we'll go into the next thing. Is the pain similar to the pericarditis? Yes, pericarditis is also a pleuritic chest pain. Any pleuritic chest pain can be there. It can be pneumonia, presents with a similar pain. It can be MPE, similar pain. Pericarditis, similar pain. They are different characteristics of these pains. What you need to remember: someone with a fever, with a cough, high-grade fever, with a expectoration, come in with a pleuritic chest pain. It is a pneumonia. Someone who has an pleuritic chest pain, which is better on leaning forward, it is a pericarditis. Someone who has a pleuritic chest pain, which is atypical, completely atypical, it might be a myocarditis. How about the pregnancy with PE? Explain in detail. IV filters. IV filters is not an emergency treatment what you will be doing it. It is done usually for an recurrent PEs which are thrown, and this is a chronic treatment. This is none of our scope, done by the vascular surgeons. As if he has recurrent PEs, what is their acute? You need to treat an acute. As an emergency physicians, do not worry about the chronic management. Pneumonia. The most commonest organism which causes pneumonia is strep pneumonia. You need to remember strep pneumonia is the most commonest bacteria which causes it. Viral infections can cause like influenza A, B, respiratory syncytial virus, mainly for the pediatric age group. Atypical pathogens, we call it, which can cause and community-acquired pneumonia is mycoplasma pneumonia, chlamydial pneumonia, or chlamydial or cocci-brunette. You can remember if you want. But the main thing what you need to remember, strep pneumonia, most common bacteria, important. Pneumocystitis jirovecii is commonly seen in an HIV patient. Okay, someone who has this, then you need to think he might be HIV positive. So you need to go ahead and get the test done for him and see whether he is HIV positive, because this is one of the diseases which is very much suggestive of an HIV, not seen in a common person. You will not be seen. If it is seen, you need to think this person might be having an HIV. Get and test done. Pneumonia, whenever it is present, you use an CRUB 65 score. It is itself is a mnemonic where C stands for confusion, gets 1 point. Urea more than 7 millimoles per liter gets 1 point. Respiratory rate more than 30 gets another point. Breathing, sorry, uh, blood pressure less than 90 or systolic blood pressure being less than 90 or diastolic blood pressure being less than 60 gets another point. Age more than 65, elderly person gets another point. Depending on that, you have the classification as mild, moderate, severe. Okay, mild, the score is 1. You can treat it with oral antibiotics and discharge them, ask them to follow up with the GP. If it is moderate, we admit. Do not consider versus outpatient. We usually tend to admit in wards. If it is severe, we ask the intensivist to come and have a look. What do you think of this patient? Do you think it requires an ICU admission? You ask them. If the score is 4 and 5, definitely requires an ICU admission. That's how you need to remember. Have a lower threshold to admit these patients because most of the time pneumonia is seen in an elderly patient. X-ray to see the consolidations, full blood count to see the WBC count, urea electrolytes mainly is required urea basically to do an CRUB score. Multi-organs might be involved and inflammatory markers, you are getting it done. Okay. What about cultures? Blood cultures, sputum culture. If it is mild and if you're planning to discharge, do not get in blood and sputum cultures. It is not recommended. If it is moderate, that means the score is 2. Then you will go ahead and get the cultures. Some institutes, depending on the region where it is, they might suggest to go at pneumococcal and Legionella urine antigen test. You might get it done. Legionella urine antigen test, you might get it done. Depending on the local protocols, this is the main thing what you need to remember. Only for moderate and severe, we get the cultures. What is the treatment? Hypoxic, start on oxygen. In sepsis, IV fluids will be required. Do not forget to give IV antibiotics. Elderly person think of bedridden for a long time because of the pneumonia, then VTE prophylaxis, that is venous thromboembolism prophylaxis might be required. Critical care involvement, if it is quite severe, severe pneumonia, then you need the critical care involvement. Pneumocystis jirovecii, as I told you, always think of an HIV. What is the classical X-ray finding what you are having? Bilateral infiltrates, what you'll be seeing. Okay, bilateral infiltrates, what you're seeing here, this might appear very much similar to that of a mealy tuberculosis. Okay, mealy tuberculosis can be very much similar, but do not ever pick up a mealy tuberculosis in an UK exam because tuberculosis itself is very, very, very rare. If they want you to test you on tuberculosis, they will give you a classical X-ray where there is an apical lesion, which is cavitatory with a long history of cough, with a trial history they'll be giving. So a very classical tuberculosis history will be given. It will be easy for you to pick it up. If this bilateral infiltration is present, always think of pneumocystitis jirovecii as the diagnosis. Treatment is trimethoprim and sulfamethoxazole, also known as codrimazole, is the treatment of choice. What do you need to remember? Tuberculosis, as I told you, apical lesion, chronic cough, weeks together, they'll be having some amount of hemoptysis might be present. A travel history to the developing countries might be present, like India, Bangladesh, Pakistan, Afghanistan is one of the diets they had given. So one of these developing countries, they'll give an usual travel history. Treatment-wise, isoniazid and rifampicin, usually we give it for 6 months. And for initial 2 months, you'll combine with an ethametol and pyrazinamide. Again, they do not test on this. This is kind of very hi-fi they feel, or this is beyond the scope of emergency physicians. We involve the chest physicians to treat for tuberculosis. We usually do not start on ourselves. So you need not even remember this. Just remember the diagnosis per se. Spontaneous pneumothorax, a very important topic from emergency, from exam point of view. Usually one question will definitely appear from spontaneous pneumothorax. Spontaneous, all of a sudden, you develop a pneumothorax. There is no trauma which has happened to your chest and developed a pneumothorax. He was fine. He was carrying out his regular activity and suddenly he has developed a pneumothorax. That is an spontaneous pneumothorax. So like any pneumothorax, he'll have some amount of chest pain, shortness of breath, reduced air entry on the affected side, hyperresonance on percussion on the affected side, reduced chest expansion on the affected side. On the opposite side, trachea might be deviated to the opposite side if it is a very bad massive tension pneumothorax if present. This spontaneous pneumothorax is again classified into two, as in primary pneumothorax and then secondary pneumothorax, which is important what you need to remember. A primary pneumothorax doesn't have any underlying lung disease. Remember, it is a lung disease. Someone has a Marfan syndrome connective tissue disorder which has led to pneumothorax, spontaneous pneumothorax. Is it a primary or secondary? It's a primary pneumothorax. It is not a lung disorder. Marfan syndrome is an connective tissue disorder. Ehlers-Danlos syndrome is an connective tissue disorder which predisposes for what? Primary pneumothorax, not a secondary. A secondary pneumothorax is there is an underlying lung disease. For example, he is a known case of asthma. Or on examination, you find out he has an underlying lung disease, or in chest X-ray has a classical feature suggestive of a COPD. A barrel kind of chest with a flattened diaphragm, a tubular heart is present, suggestive of a COPD. Then you consider it as a secondary pneumothorax. Most of the time, he would have been a known case of a lung disease, or what you need to remember, he must be a smoker plus age more than 50 years. This is important. Confusion happen here. Let me give you an example. Someone who is an 44 years old and a chronic smoker, he smokes 10 packs per day. Let's take it for an example. Is he an secondary pneumothorax? No, it is not a secondary pneumothorax because age also needs to be satisfied. He needs to be more than 50 years. So more than 50 years, someone, for example, will take it as 56 years he is, plus he is a smoker. Yes, this is an secondary pneumothorax. Way to measure for the pneumothorax. You can either measure it at the apex or at the hilar region, doesn't matter. Previously, they used to say that at the hilar region, you need to measure it. Now it is gone. You can measure it at the apical region or the hilar region, doesn't matter. Do not follow this. This is an old guidelines of 2010 BTS guidelines. This is almost 2 decades old. Sorry, 1.5 decades old. It is, do not read this. This is the latest one. It has come out in 2023. This is the latest one. What you need to remember. This one looks a little bit complicated. That's why I have broken down here. In this here, there are few things which are given not in the tabular form in the literature. For that reason, I have made few changes, but it is completely adopted from the BTS guidelines. We are not deviating from the BTS guideline. Significant symptoms are present. Doctor, I have severe chest pain, a significant symptom. Or someone says, I have mild chest pain, not a significant symptom. Someone comes, I have a chest pain, but his oxygen saturations are on the lower side, significant symptom. Hemodynamically unstable, significant symptom. If the symptoms are insignificant, or he says, I have just mild chest pain, mild shortness of breath, that's why I came here to show it. You find out it is an pneumothorax. What you do? It's a conservative management, what you want. So no significant symptoms, go ahead for an conservative management. Do not forget that point. Significant symptoms are present. Then you are checking whether the patient is unstable. Unstable means systolic blood pressure being less than 90. If the systolic blood pressure is being less than 90, consider this as an tension pneumothorax. Any patient who is an unstable patient is a tension pneumothorax. By definition, you need an decompression. So you can do a needle decompression. Okay, you can do a finger thoracotomy, but finger thoracotomy more preferred in trauma cases. Okay, than in medical cases like a spontaneous pneumothorax, you can do a needle decompression. If the saturations are less than 92% or bilateral pneumothorax, or there is an underlying lung disease, age more than or equal to 50 years plus significant smoking, these two are nothing but secondary pneumothorax they're talking about. Or this pneumothorax is associated with some amount of blood. At that point of time, what you do, all these patients definitely requires an ICD. Some might require a needle decompression followed by an ICD because they have an intention. Otherwise, you directly go for an ICD. Before you go ahead and ICD, measure the size. Okay, you are measuring the size here. How big? If someone gives me this X-ray, I will say it is more than 2 centimeters. Obviously, at the apex, I'll see this is more than 2 centimeters anytime. It might be around, at least it might be around 10 centimeters, what I feel. That's how you can pick it up on an X-ray what you're given. Grossly, you can find out what has been given on an X-ray. If it is more than 2 centimeters, then you can easily place an ICD. So directly you'll go ahead and place an ICD and admit him and start him on oxygen. You start him on oxygen because studies have shown that if you start him on oxygen, in spite of oxygen saturation being in the normal range, the recovery is much faster. For that reason, you're starting them on an oxygen. If the chest X-ray, if the size is less than 2 centimeters, okay, it's 2 centimeters, you can CT scan done to precisely see where the ICD needs to be placed. CT guided ICD placement, what you'll be doing basically here. None of these features are present. Then what you will do? Then in X-ray, you will see whether the size of the pneumothorax, apex or hilar region doesn't matter. If it is more than 2 centimeters, what you will do? If it is less than 2 centimeters, then again, it is a conservative management. If it is more than 2 centimeters, you give the patient option. What options you can give? Whether you want any intervention. Doctor, I'm scared of interventions. Can some conservative management can be done? Yes, can be done. No, I want immediate symptomatic relief. Then you will go ahead with needle aspiration. Immediate symptomatic relief he wants to be feel better. It should be done immediately. Then you go ahead with needle aspiration. What about ambulatory device? Ambulatory device is also one more option. If they want immediate symptomatic relief, they can be discharged with OPD follow-up. This is known as ambulatory device, which is inserted in the second intercostal space. This is not very commonly available. Most of the trust doesn't have it unless it is a well-established pulmonary department. They have it. They'll not have an ambulatory device. So most of the time, this option might not be given in the exam. If given, you are aware of that one. So either of this ambulatory device or needle aspiration, the option again will be given to the patient. In needle aspiration, what you'll do? You'll aspirate. Okay. You'll keep on aspirating. You'll aspirate enough air. Then you see whether the patient has improved. Yes, improved, then you can discharge him. If not, then you need to insert an ICD. This is the needle aspiration, what you are doing it. Okay. Again, needle aspiration, there are few things what you need to remember is maximum what you can aspirate is 2.5 liters. More than this is not recommended. Conservative management, I keep on talking about conservative management. In conservative management, you need to see whether the patient is primary spontaneous pneumothorax or in secondary spontaneous pneumothorax. If it is a secondary spontaneous pneumothorax, you need to admit this and follow up, or basically you'll admit and for close observation in the wards, you'll be admitting him if it's a secondary spontaneous pneumothorax. If it's a primary spontaneous pneumothorax, you can ask them for OPD follow-up. You can discharge them and follow up in the OPD with the chest physician. So most of the time, it is the air, spontaneous pneumothorax, only air is present. If air is present, small bore or small size chest tubes are preferred. For a small size chest tube insertion, Seldingham's technique is preferred. Or Seldingham's technique or Seldingham's drain is recommended. This usually is the things what you use it. A guide wire is there. Through the guide wire, you just pass it. You do not even make an incision. Where is it placed? It is placed like any other ICT what we have spoken about in the trauma class. Fifth intercostal space, slightly anterior to the mid-axillary line, is the preferred side. But anywhere you can place it in an anatomical safe triangle if this side is contraindicated for some reason because it might be an overlying infection. More about ICT insertions we'll be talking about in the procedure class. At the same point of time, I would like to make an point here. A lot of confusion usually will arise here. What about large bore want you place? When do you want to place a large bore? Whenever you want to drain and liquid. For example, it might be a blood. For example, it might be a pus. You need a large size ICD. That is intercostal drain should be a larger size because it is a liquid what needs to be drained. It might cause obstruction if you use a smaller size one. So that's why in trauma, most of the time it is an hemopneumothorax, not only pneumothorax, blood, some amount of blood will be there. For that reason, you need a large size. Someone you're putting an ICD who has a pleural effusion, then you need a large size. It might be transmitted or exuded pleural effusion, but you need a large size. For a large size, open technique is required. Where you make an incision, do an blunt dissection, open technique is required. This is the differentiating factor. I spoke about an pleural aspiration here. This is the needle aspiration or the pleural aspiration, what I spoke about. It is different from needle decompression. Pleural aspiration is done in second intercostal space, mid-clavicular line. Needle decompression is different. You put a needle to decompress the tension what is present. Pleural aspiration is you're aspirating the air what is there. Two are different things. The position is different in adults. It is in second intercostal space, mid-clavicular line for pleural effusion. For needle decompression is fifth intercostal space, slightly anterior to the mid-axillary line. Thus, the differentiating factor what you need to remember. Discharge and follow-up, patient should be advised to return to the hospital if any worsening of the symptoms are present. He becomes more breathless. He needs to come back to the emergency department. All of them should follow up with the chest physician, that is respiratory physician, till complete resolution is present. Air travel should be avoided till complete resolution. That means a clearance is given by the respiratory physician. Do not fly. Okay, do not take any airplanes, any flights at all. Diving, it's a deep sea diving, water diving, what I'm talking about. It should be permanently avoided. He shouldn't never ever do a deep sea diving. He needs to do it because it is his profession or his habit. He wants to do it. Then you refer to the chest physician. They have to go and surgical pleurectomy. Their lung function test should come in normal, and post-operative CT scan should be normal. So many conditions needs to be satisfied if he wants to start diving. That's what you need to remember. That is very important. Hemoptysis. Hemoptysis is coughing up the blood. Coughing up the blood, you can see here there are various lung causes. It might be just the inflammation, it might be infection, it might be infraction, it might be an malignancy, it might be an abscess, it might be an trauma. Sometimes we do not know because of an instrumentation, it might be, sometimes it might be an idiopathic. Most of the times it is an infection or an cancer what they present with. Sometimes it might be a cardiac cause, like an PE, left ventricular failure, stenosis, pulmonary hypertension, or an fistula between aortobronchial fistula might be present. Or vasculitis like an SLE, vaginous, or Goodpatcher syndrome can be there. The importance of this slide is there are various causes for hemoptysis. Not get overwhelmed and try to mug up everything, not required. You need to just remember that infection, inflammation, abscess, cancer, trauma, cardiac causes, and vasculitis can cause hemoptysis. That is enough, and move ahead for the treatment plan. Treatment plan, first thing is, when do we call it as a massive hemoptysis? If he has coughed up more than 400 ml in last 3 hours, or if he has coughed up more than 600 ml in last 24 hours, then you call it as a massive hemoptysis. Management plan, correct him on an high flow oxygen. Okay. Place the bleeding lung dependent. So what is the bleeding lung dependent? What do I mean by this? So this is the lungs which is bleeding from here. Okay. So this should be on the dependent side. What do I mean by dependent side? How do you do it? This is the right lung, left lung. You should go into the left lateral position. Going into the left lateral position, this lung side will be on the lower side. This lungs will be on the lower side. Due to the gravity, the blood gets settled here. It will not come into the bronchus, into the trachea, will not be coughing up. As the blood gets settled here, this might cause an tampon effect and stop the bleeding. That's the idea behind it, placing the deep bleeding lung dependent. Basically, on that side, he'll go laterally. Bronchoscopy eventually will be required. A rigid and fiber optic combination will be done. This should be done in a general anesthesia by an just physician, cannot be done by the emergency physician. Usually the bleeding is stopped by embolization. If it is a cancer, they can do an radiotherapy and try to stop it. Potential sources of error with an pulse oximetry. You are using a pulse oximetry, wrong readings can come up if you are dark skinned. If the patient has a severe hypotension or systolic blood pressure 80, 70, it cannot pick up. Okay, there should be good pulsatile flow of the blood should be present to pick it up. Sometimes a venous pulsation can pick it up wrongly, and venous saturations it might be showing rather than an arterial saturations. Abnormal hemoglobin like carbon monoxide poisoning or methemoglobinemia can give abnormal saturations. Intravenous dyes like methylene blue can cause high lipid values, or someone who is on propofol infusion. Nail polish, if they are using blue or black or green color nail polish, it will give false readings. You need to remember this. This is more for the practical purpose. APG, how to diagnose APGs. The normal range I have given here, you need to remember this. Okay. I want you to remember these values in kilopascals, especially, and go to the exam. Sometimes they will give the normal range. Sometimes they may not give the normal range. If you're aware of the normal range, you need not search where is the normal range given. What is this? You will waste a lot of time. APG readings are very frequently given in the questions. So be aware of this APG readings, what has been mentioned here. There are only 4 readings what you need to be aware of. It is very helpful for your exam. Remember this before you go to the exam. First thing what we are seeing is respiratory failure. There are 2 kinds of respiratory failure, type 1 and type 2 respiratory failures. Type 1 respiratory failure is basically hypoxia. PaO2 values will be on the higher side. PaCO2 values will be in the normal range. Type 2 is basically PaCO2 values will be on the higher side. PaO2 can be normal or can be on the lower side. Doesn't matter. We only see a PaCO2 values. If they are high, it is a type 2 respiratory failure. Only PaO2 values are on the lower side, then it is an type 1. In type 1, carbon dioxide, that is PaCO2 values should be normal. Type 2 is further classified as acute, chronic, acute and chronic. In acute, what happens? In acute, acutely PaCO2 values will go high. As acutely it has gone up, PaCO2 is nothing but an acid. The pH will go low. It becomes acidotic. Whenever the pH is on the lower side, we call it as an acidosis. So it becomes acidosis. What about the bicarb? You need to remember bicarb changes takes longer time. The changes are brought about by the kidney. Kidney takes longer time to change the bicarb values. It cannot acutely change it. That's why it remains in the normal range. So acute type 2 respiratory failure, pH will be low. PaCO2 values will be high and bicarb will be in the normal range. In chronic, what happens? In chronic, PaCO2 values are chronically high. So kidneys have enough time for for the bicarbs to retain. If the bicarbs are retained in your body, this will go high. This is nothing but an base. A base plus acid will neutralize, will eventually will result in a normal pH. For that reason, these patients will have normal pH, high bicarb because kidneys had enough time to retain the bicarbs and high PaCO2 values. This is known as chronic type 2 respiratory failure. What is acute on chronic? There is chronic. Sorry. There is chronic. In chronic, what we'll be seeing, high bicarbs will be seen because chronically PaCO2 values are on the higher side. That's why you are seeing an high bicarb values because kidney had enough time to compensate it. Okay, but what has happened? An acute insult has happened on the chronic. That's why it is known as acute on chronic. Due to the acute insult, by carbon dioxide values are gone on the higher side, more higher than what it was. For this higher PaCO2 values, kidney didn't had enough time to compensate and bring the bicarbs also on the higher side. That will result in the pH falling down. That is nothing but acidosis. So acidosis, that is pH will be on the lower side, PaCO2 values will be high, and bicarb also will be high in acute on chronic type 2 respiratory failure. That's the differentiating factor. Next thing, how to look at an ABG itself. Once you have an arterial blood gas, how you will be looking at? First thing what you'll be looking at is the pH. If the pH is less than 7.35, you call it as an acidosis. If the pH is more than 7.45, you call it as an alkalosis. The normal range of the pH is 7.35 to 7.45. This is the normal range. Strictly, your body tends to maintain the pH in the normal range so that all the metabolism in your body takes place as expected. A pH going alkalotic or an acidosis is not preferred for your normal metabolism, normal functioning in your body. Okay, your functioning will go haphazard if the pH changes. First, we'll be seeing acidosis. The two parameters what you need to look out for is PaCO2 values and bicarb values. If the PaCO2 values is on the higher side, we call it as a respiratory acidosis. If the bicarb is on the lower side, we call it as a metabolic acidosis. Remember that bicarbs are alkali. PaCO2, that is carbon dioxide, is acidotic. So respiratory acidosis, yeah, metabolic acidosis because the alkali have gone lower side. What if you have an PaCO2 on the higher side and bicarb on the lower side? This is known as mixed. It is a mixed of what? Respiratory and metabolic acidosis. This is a mixed respiratory and metabolic acidosis. Okay, in mixed respiratory and metabolic acidosis, no compensation can happen. There is no compensation at all which can happen. Again, we'll go back to when PaCO2 being on the higher side, it is a respiratory acidosis. Along with this, if there is a high bicarb also, then we call it as a respiratory acidosis with partial metabolic compensation. The important term what you need to remember is here is the partial term. Why we call it as in partial? Because the pH has not come back to the normal. That's why it is always an partial compensation. It cannot be a complete compensation. Next thing what we are seeing here is a metabolic acidosis because the bicarb is on the lower side and the pH is less than 7.35. That's why we call it as a metabolic acidosis. Along with this, if the PaCO2 values are on the lower side, that means he is breathing fast, hyperventilation, and washing out the carbon dioxide to bring the pH to the normal value. This is known as metabolic acidosis with partial respiratory compensation. Again, we are using partial because the pH has not got back to the normal. It is always partial. Now we are coming to the alkalosis. Alkalosis, we are aware that if the pH is more than 7.45, we call as alkalosis. If by PaCO2 values are on the lower side, it is respiratory alkalosis. If bicarb is on the higher side, we call it as a metabolic alkalosis. Same two things what we saw in acidosis, we are seeing here. They are going in opposite direction here so that it becomes alkalotic. If both are present, if both are present, then we call it as a mixed alkalosis. Mixed alkalosis cannot have an compensation. Now we will see only respiratory alkalosis. So PaCO2 values are low. We call it as a respiratory alkalosis. Along with this, if the bicarb is on the lower side, we call it as a respiratory alkalosis with partial, again term partial metabolic compensation. If the bicarb is on the higher side, we call it as a metabolic alkalosis. Along with this, if there is a PaCO2 values on the higher side, we call it as a metabolic alkalosis with partial metabolic compensation. Again, partial is the important term what you need to remember. Everywhere it is partial, 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 partial. There is further. This further is for your further study. It's mainly will be tested in FRCM exams, not in MRCM exams. So this slide is for you to study. It is not required for MRCM exam. So I am not spending time on this slide. Anionic gap. The normal range of anionic gap depends from lab to labs, from literature to literature. Usually they say from 4 to 12. Some literature says it is between less than 18. You can consider it as a normal range. But how do you calculate an anionic gap? Cations minus anions is the anionic gap. That is sodium plus potassium minus chloride plus bicarb. Most of the time, potassium what you are measuring is on the very lower quantity. So some formula says sodium minus chloride plus bicarb, you can use it. Okay, the more precise one is using this formula is the most precise one. If potassium values are not given, then you can use this value also. It gives approximately similar range. What are the causes for metabolic acidosis? Metabolic acidosis with high ionic gap. Metabolic acidosis with normal ionic gap. They cannot be in low ionic gap. Okay, so either it has to be in the normal range or it has to be in raised ionic gap. So metabolic acidosis can be classified into two. Once you classified into two, depending on the anionic gap, you have different causes. That's why it is important to classify. Here you can remember with a mnemonic known as mud piles. Okay, this is a mnemonic what you are having to remember the causes for metabolic acidosis. That is methanol, uremia, diabetic ketoacidosis, parahaldehyde toxicity, iron or isoniazide toxicity what you are having, lactic acidosis, ethanol or ethylene glycol, and salicylate poisoning. These are the main things what you need to remember. In metabolic acidosis with normal anionic gap is an important one. There are only few causes what you need to really concentrate and remember. A diarrhea can cause, remember this, a diarrhea can cause hypoaldosteronism. Hypoaldosteronism is nothing but Addison's disease. In Addison's disease, you see normal anionic gap. I'll be repeating this in nephrology chapter. Remember, endocrinology chapter. Addison's disease, nothing but hypoaldosteronism is causes normal anionic gap. Use of certain drugs like carbonic anhydrous acetylzolamide causes normal anionic gap metabolic acidosis, along with ammonium chloride, magnesium chloride. What are this? These are nothing but antacids. Antacid syrups would be prescribed commonly for reflux GRDs. These antacids also, if taken in large amount, can cause metabolic acidosis with normal anionic gap. So things what you need to remember is diarrhea can cause, Addison's disease can cause, certain drugs like carbonic anhydrous and antacids can cause, antacids like ammonium chloride, magnesium chloride. Metabolic alkalosis. Metabolic alkalosis, the opposite of Addison's disease is Conn's disease or Conn's syndrome, what we call it, can cause it. Your stomach most of the time has an acid, that is an HCl. If you suction this HCl out, or this HCl is coming out because of the vomiting, this can cause metabolic alkalosis. Hypokalemia itself will push the hydrogen ions inside the cell in exchange of potassium to bring the potassium in the normal range, can lead to metabolic alkalosis. Okay, massive blood transfusions, you see you see metabolic alkalosis mainly because the blood is stored in the citrate medium. Presence of the citrate can trigger an metabolic alkalosis. Respiratory acidosis. Respiratory acidosis means this patient is hypoventilating. There is respiratory depression. Why respiratory depression is present in this patient? Because CNS depression is present, low consciousness, Neuromuscular diseases like an Guillain-Barré syndrome can cause this. Myasthenia gravis can cause this. Impaired lung function like an COPD can result in respiratory acidosis. Acute airway obstruction like an foreign body aspiration you are having or an angioedema you are having can lead to an respiratory acidosis. Respiratory alkalosis, something which is causing you to breathe fast because you're anxious, you are at a high altitude, you are having a fever. Pregnant woman, because there is fetus which is compressing the diaphragm and causing hyperventilation. CNS stimulants, sorry, any CNS pathology like an stroke, uh, SAH, the subarachnoid hemorrhage, meningitis. Certain medications like salicylates can cause this one. Sepsis, metabolic acidosis, to compensate, you might start breathing and can have an respiratory alkalosis. Poisonings like carbon monoxide, hyperthyroidism, liver failure. Main thing what you need to remember here is most of the time it is physiological respiratory alkalosis what we'll be having, like an anxiety, altitude, fever, pregnancy. The pathologies what you need to remember is CNS insult is present, which can trigger this one. Another one what you need to remember is salicylates. Salicylates causes increased in respiratory rate resulting in increase in respiratory rate resulting in respiratory alkalosis. These are the two important things. Otherwise, it is mainly physiological what you need to remember. Sarcoidosis. Sarcoidosis, or sometimes it can be interchanged with loaf grain syndrome. There is little bit subtle changes what you need to there are subtle changes. They are not one and the same, but the presentation is very common. Sarcoidosis, hilar lymphadenopathies will be there. Acute polyarthritis, that is joint pains, will be there, along with a lesion over the shins that is known as erythema nodosum. So erythema nodosum, joint pains, and hilar nodes are enlarged. Classical presentation for sarcoidosis. Again, refer to the rheumatologist. You will not be doing much. Asbestosis causes interstitial lung disease. Asbestos exposure happens in anyone who is a shipyard worker, especially retired shipyard workers, miners, or pipe fitters. In them, you can see it. This can predispose to mesothelioma, which is nothing but cancer of pleural. It is a tumor or a cancer of an pleura. Mesothelioma is a tumor of an pleura. Pancoast tumor. Pancoast tumor is an apical tumor what you are having. At the apex of the lungs, you are having a lesion. That is a tumor what you are having. Because it is an apex here, closer to it are the sympathetic chain. And closer to it is a recurrent laryngeal nerve. Compression of recurrent laryngeal nerve will result in hoarseness of voice. Compression of the sympathetic chain can result in Horner syndrome. So the symptoms what you can remember is 2H. One is the Horner syndrome. One is the Horner syndrome, what you are having. Another one, what you are having is hoarseness of voice. What is Horner syndrome? Horner syndrome is a triad. There are various causes for Horner syndrome. Everything causes compression over the sympathetic chain. Whenever there is a sympathetic chain which causes compression, which is found above the level of T6, results in an Horner syndrome. Horner syndrome results with anhidrosis, that is no sweating on that affected site at all. Anhidrosis can be seen. Ptosis, drooping of the eyelid, upper eyelid, particularly upper eyelid, along with meiosis, constriction of the pupil. So three things is completely dry, no sweating is seen on the affected side. On the affected side eye, the pupil will be constricted, known as meiosis, and there will be drooping of the eyelid on the affected side. This is upper eyelid. This is known as ptosis. This is the triad what you see in the Horner syndrome. Again, refer, you cannot do much in the emergency department. Pleural effusion. Pleural effusion, what you need to see in the X-ray is look at the costophrenic angle. This angle, what I'm drawing here, is the costophrenic angle. There is obstruction of the costophrenic angle. Again, the fluid will cause a crescent kind of shape here, meniscal kind of shape here. That is because of the accumulation of fluid. This is pleural effusion. Fluid is accumulated in the pleural space. We do not intervene in the emergency department unless and until the patient is unstable. If the patient is unstable, you might have to do an aspiration to relieve the pressure on the lungs, lung parenchyma. Otherwise, you do not aspirate. You do not do anything at all. Sometimes they might test you on the lights criteria. Again, it is more for the physicians. It's slightly on the low yield side, what you can call it. But you never know, they might test you on this. Okay, how to lights criteria will help you to differentiate from the aspirated fluid from the pleural space, whether it is a transudate or it is an exudate. Thing what you need to remember is the pleural fluid always comes up, followed by the findings of the serum. Findings of the plural always comes up when you are taking a ratio. The plural to serum protein ratio, if it is less than 0.5, it is more of a transudate. Plural to serum LDH value less than 0.6, or pleural fluid with an LDH which is less than two-thirds of the upper limit of the normal, then you need to think of an transudate. Exactly opposite is present for an exudate. Transudate, whenever is present, usually it will be bilateral pleural effusion will be there, and systemic disorders will be there, like an heart failure, liver failure, kidney failure, or an PE. Whenever it is an exudate, you need to remember two important things. It can be an malignancy, infection, including tuberculosis can be present. PE, I have put up here both sides. Sometimes it can be transudate, sometimes it can be exudate. So do not use it to differentiate the exudate or transudate as a cause. Main important causes are systemic causes for transudate. Remember that. For exudate, infection or malignancy, including tuberculosis. Last topic is ARDS. Okay, acute respiratory, sorry, ARDS is acute respiratory failure, what you're seeing here in this patient. So what happens in ARDS? That is very important. What is the definition of ARDS is very important. ARDS basically is acute respiratory distress syndrome. Okay, there is a Berlin's criteria, or in definition of this one is known as Berlin's criteria, what you need to be aware of. Symptoms begins within 1 week of insult, or new or worsening symptoms of 1 week. On a chest X-ray, you see bilateral infiltrate very bad. It looks like an whiteout. Bilateral opacity is on the chest imaging, what you can see. This bilateral chest image, what you are seeing, should not be able to explain by an fluid overload, because pulmonary edema also has similar findings. It shouldn't be like, oh, this patient has a cardiac failure, that's why he's having. No, they shouldn't be able to explain it with the cardiac failure. No, his ejection fraction is good. Still, he has a bilateral infiltrate on the chest. What is it? It is an ARDS, what you need to think at that point of time. Along with the ratio of PaO2 to FiO2. PaO2 is a value what you get it on an ABG. Divided by FiO2 is basically fraction of inspired oxygen. If this value is less than or equal to 300, if it satisfies all these four criteria, then you call it as an ARDS. ARDS is further classified as mild, moderate, severe. Mild is also known as acute lung injury, depending on this ratio. If the ratio is between 200 to 300, it is mild. 100 to 200, it is moderate. Less than 100, it's severe. This is what you need to remember. This is the definition of ARDS. This is known as Berlin's criteria. I'll just go through the questions before we enter into the recall questions. CRUP 65 is used for all age groups, including pediatrics. No, pediatric is different. Okay, it is only used for the adults. Pediatric we'll be discussing in the pediatric chapter. Secondary pneumothorax lung disease is a chronic lung disease or an acute infection of lung. It is a chronic lung disease, secondary pneumothorax. I never spoke about any acute infection. It's a spontaneous pneumothorax what is happening. Do not mistaken with any infection. When we use 18 to 32 ICD, as I explained you, when you want to drain and fluid, when there is a complete compensation, where do I look first? If there is a complete compensation, the pH will be normal. So you will not be looking for acidosis or alkalosis at all. Complete compensation, you call it if the pH is normal. That's why I told you complete compensation is not possible at all. If complete compensation is present, there will be no acidosis at all. So you cannot explain it at all. By chest X-ray, how to differentiate between tuberculosis and lung tumor Pancoast? Look for an cavitary lesion. Okay, Pancoast tumor. It is a soft tissue lesion what we'll be having. A cavitary lesion will not be there. Along with it, look for an history. A chronic history of weight loss is present. You go more within Pancoast tumor. Tuberculosis, a history of cough lasting for weeks together. A history of travel is present. Along with some amount of hemoptysis is present. Then you are thinking of an tuberculosis. If there is a low PaO2 and high PaCO2 values, can it consider mixed respiratory failure or type 1? There is nothing known as mixed respiratory failure. Either it is a type 1 or type 2 respiratory failure. In type 1 respiratory failure, you will have low PaCO2 values, PaO2 values only. The PaCO2 values will be in the normal range. This is type 1. In type 2, PaCO2 values will be on the higher side. PaO2 values, it can be low, it can be normal. As suggested. No need to check for all points for Krupp score. You need to check all the points. Why do you want to not check all the points? Is it necessary to do an BNP in ARDS if required? If you're confused between a cardiac failure and the lung disorder, then you might have to do a brain natriuretic peptide, what you're talking about. You might have to get it done at that point of time to differentiate between the two. Again, why do you do it? As we learned in the cardiology chapter, you want to go ahead with more of more confirmation you required for the cardiac failure. This the cause is there. Then anti-pro-BNP can be get it done. When we use CRUP 65, you use it in a pneumonia case. Anyone who has a lung infection, you want to decide what is the further course of treatment, you use a CRUP 65 score. We are entering into the recall questions now. That answers all the questions what everyone had. So we will enter into the recall questions. The first one, what we are having is a 22 years old professional athlete is suffering from an Achilles tendon rupture and the patient is on POP slab for last 1 week. While he was waiting for an Achilles tendon repair surgery for the last 2 days, he has developed an pain and swelling in the same leg. He has taken multiple painkillers without much effect. What is the next best step in management? What are we suspecting? We are suspecting strongly of an DVT here. So whenever we are suspecting strongly of a deep vein thrombosis, what we'll be doing? We'll be doing an 2-level modified Bell score. Immobilization gets 1 point, swelling gets 1 point. Whenever the score is 2 or more than 2 for that matter, we go ahead and directly get a Doppler scan done of the lower limb. So the right answer here is Doppler scan of the lower limb. Again, one of you asked as a, I think CRP we useful for all ages. I have already replied to you. You only use it for the adults. CRP, I don't know what you mean by. If you're asking about Krupp score, we only use it for adults. We are not discussed about pediatrics here. A 49 years old presented to the ED with complaints of cough with expectoration for last 2 to 3 weeks, has taken on-the-counter medications with little to no improvement. He is a known case of diabetes and is on metformin for the same. He gives a history of travel to India 1 month back. On examination, patient seems to be quite stable. For that matter, X-ray is given to you. 2 to 3 weeks cough. Travel to India is present. On an X-ray, you see a cavity lesion. Why do I call it as a cavity lesion? You can see whitish, and here in between, there is a black. That's why we call it as a cavity. Cavity is present. Black color is present in between. Keeping all this in mind, it is a classical history of tuberculosis. So you shouldn't be missing this diagnosis. A 60 years old male was brought to the emergency department with acute shortness of breath. He is a known case of IHD tuberculosis, and 2 months back he had a stroke for which he had a thrombolysis done. Vitals are hypotension is present, quite significant. Systolic blood pressure is less than 90. I can call it him as an hemodynamically unstable. After stabilizing the blood pressure, you get an CTPA done, which confirms an mass UPE. The most appropriate management plan for this patient is what you will be doing. You need to remember, when do we do an thrombolysis in the patient? We do an thrombolysis if the patient is unstable. Next question is, when do we call it as an unstable? It's only the systolic blood pressure what you need to look out for if it is less than 90. This patient had a systolic blood pressure less than 90. So we are thinking of an thrombolysis. But thrombolysis cannot be done for this patient because this patient had a stroke and recently a thrombolysis was done. This is a contraindication for thrombolysis. So what next can be done? Best thing, you can do an radiological embolectomy can be done. So radiologically, you can go and mechanically break down the clot which is present. This will be the preferred one rather than doing an intraarterial thrombolysis or just doing an intravenous thrombolysis. Not used for all ages. It is used whoever are 65 age, or you use it for every adult. If it is more than 65, you're giving 1 point. As I told you, adult. A 33 years old woman is admitted with sudden onset of shortness of breath while shopping in the supermarket. She has no other symptoms but had had an laparotomy and removal of the uterine fibroids 3 weeks back. She has no other past medical history, is a non-smoker. Observation wise, there is some amount of tachypnea, saturations are fine, heart rate is fine. On examination, her chest is clear. Her heart sounds are normal. There is no swelling and tenderness in the lower limbs. What is the correct well score for this patient? Is the PE more likely in this patient? First thing you need to ask, is PE most likely in this patient? Sudden onset goes in favor of PE. Previously, this patient had an immobilization or major surgery was done, fibroid was removed, laparotomy was done there. Keeping these two in mind, I'm thinking of in PE. PE is one of my first differential diagnosis. So PE is likely here. That's why I give 3 points. You get it there. Along with it, there is an immobilization what is present here, or a surgery, previous surgery was done within last 3 weeks or 3 weeks ago it was done. So this itself gets 1.5. So the total will become 4.5 for this patient. There is no tachycardia for me to add it. Heart rate is less than 100 here. So that one is not there. No other parameters are given to add up in the well score. So the total well score what we are having is a 4.5. A 32-week pregnant lady complains of shortness of breath for a couple of days. Breathing difficulty is associated with chest pain, which is worse on deep inspiration. She has no comorbidities. Her regular medications includes iron and folic acid. Observations are as follows, which looks completely stable. You are strongly suspecting PE, and CTPA was done, which showed an submassive PE. PE is present. The best treatment option for this patient. The thing what you need to remember, she is pregnant. If she's pregnant, then best option becomes low molecular weight heparin. If I remove off pregnancy, then the best would have been of these options, direct oral anticoagulants. A 45 years old male unknown chronic smoker presents to the ED with complaints of shortness of breath since a couple of hours. He is a known case of hypertension and diabetes. Okay, and the parameters are given given here. Looks fine, fine. Some amount of tachycardia. Saturations are on the lower side. X-ray is done, which shows right pneumothorax. Okay, so he's a 45 years old. Shortness of breath he has presented with, and he is a chronic smoker. In a hilar region, there is a 2.5 centimeters, and there is at the apex, it is 4 centimeters. What is the next best step? What is the next step? What do you need to remember here? So, what do you need to remember is first point what we'll always ask for is the symptom significant? Yes, the symptoms are significant because the saturations are on the lower side. It has to be significant. He is breathless. So it is significant symptom. Next thing we see is in a column what I had mentioned you there, saturations, SpO2 was there. Saturations on the lower side. It is on the lower side. If present, then you directly go ahead with placement of an ICD. Do we need to get a CT scan done here? No, not required because the size of the pneumothorax is 4 centimeters. It's large, more than 2 centimeters, obviously. So the right answer here is just drain insertion. No, it is not an secondary spontaneous pneumothorax because the age is 45. Remember that age is 45. Age has to be equal to or more than 50 years to call it as a secondary spontaneous pneumothorax. Next point is if the age was, for example, 65 years and was chronic smoker also, the thing remains, the management plan remains the same. It doesn't depend. It is a primary pneumothorax, primary spontaneous pneumothorax, or a secondary spontaneous pneumothorax. The treatment remains the same. A 78-year-old male presents to the ED with complaints of swelling of the entire lower limb. Associated with the pain. 3 days back, he had undergone an total hip replacement surgery. He is a known case of gout, rheumatoid arthritis, and was previously diagnosed with lower limb DVT. And was warfarin for 6 months. On examination, he is hemoglobin stable. What's the well score for this patient? They're asking. So well score, 1 point here, another point here, another point here. Adding up, it will become 3. Total point is 3. So we are having well score of 3. A 28 years old female presents to the ED with complaints of shortness of breath and since 1 week with gradual worsening. She denies any cough or fever. She gives an history of road traffic accident a month back. There is no significant past medical history. Vital parameters are grossly normal, slightly lower side SpO2 what you are having. Just is shown what is the likely diagnosis here. Bowel loops are seen in intrathoracic cavity. 1 month back, this patient had a trauma. Most likely at that point of time, there was some amount of diaphragm injury. And over the time, there is herniation of bowel loops which has happened, which has resulted in diaphragmatic herniation, entering of the bowel loops into the thoracic cavity, what you're seeing here. So it is a diaphragmatic rupture, what do you need to think of? Because the history of trauma is present. If the history of trauma is not present, then we would have thought of Chilaiditi syndrome, Ciliary syndrome is basically a medical condition where the bowel loops are seen in between the liver and the diaphragm. But here it looks more like intrathoracic. A, el- a elderly female presents to the ED with shortness of breath and cough. She has a significant history of hypertension COPD. You make a diagnosis of acute exacerbation of COPD and start on medical management. After 1 hour of medical treatment, ABG shown below. This is the ABG what you are having. What is the indication to start on an NIV? Indication to start on an NIV, we already aware the pH being less than 7.35. Then we have an PaCO2 values being more than 6.5 and respiratory rate being more than 23. There are two indications here. One pH being less than 7.5. Another one is PaO2 being 8.8. Which one to choose? Remember that pH less than 7.15 is a relative contraindication. So do not choose this one. That's why you are choosing an PaCO2 values of 8.8. A 19 years old female with a history of asthma present to the emergency department with increasing breathlessness and wheezing. She has been using increasing amount of salmeterol inhalers over the past few days. On examination, the respiratory rate is 35, heart rate is 130, saturations are 91% on room A. There is tachycardia, there is tachypnea, along with low saturations, which is less than 92. The patient is unable to talk in a full sentence. She has a widespread risk throughout her lungs. And the ABG is given here where the PaCO2 values are in the normal range. How severe is this patient's asthma? They are asking. Two parameters are suggestive of an life-threatening asthma here. One is SpO2 values being less than 92%. Here 91%. It's a clear. Another one is despite this patient having these symptoms, that means despite the patient having tachypnea, hyperventilation, the bicarbonate values, that is PaCO2, sorry, not bicarbonate, the PaCO2 values are in the normal range. This is also suggestive of an life-threatening asthma. There are two factors who are suggestive of an life-threatening asthma. If I change this answer, for example, saturation for 94%, still it is a life-threatening asthma because PaCO2 value is in the normal range. 66 years old female who was in a flea market developed an acute onset of breathlessness. Bystander immediately called an ambulance. On arrival to the ED, her observations are as follows. Important thing is low blood pressure, systolic blood pressure being less than 90, and hypoxic. She has underwent appendectomy 2 weeks back and is a known case of hypothyroidism. So immobilization history is there. What is the most appropriate next step in the management? So because of this immobilization, because of the acute onset what is present, I'm strongly suspecting of an pulmonary emboli. Can I directly go ahead and get an CTPA done for this patient? No, because this patient has a low blood pressure. So CTPA is not an option. D-dimer, well score is quite high. If you calculate again, D-dimer acutely will not be much helpful. So we are left with altiplase. We are left with rivaroxaban. We are left with 2D echo. The right answer here is to do an 2D echo. Why? We need an indirect evidence of an PE. On an echo scan, if you get it done, you will see an RA-RV dilatation. If this is present, then you go ahead and do an thrombolysis. At that point of time, altiplase will be the right answer. So before giving altiplase, get an 2D echo done. Rivaroxaban, a direct oral anticoagulant, is for unstable patient, not for an unstable patient. It's a stable patient. So the right answer here is to get an 2D echo done. This has repeated in September 24 also. Okay, remember this repeated twice. It repeated, but many people got it wrong in September 24. I don't know. That's why I'm spending so much of time here. Concentrate here why we are choosing 2D echo. A 57 years old female, a known case of COPD, complaints of a cough with expectorations and fever since couple of days. Observation shows an respiratory rate of 21 and saturation on the lower side. And these are the vital parameters with febrile. And ABG is done. What is the interruption of an ABG? pH is on the lower side. Low pH means it is an acidosis. I'm aware of this one. Next, whenever I see an acidosis, I see two parameters, PaCO2 values, CO2 values, and bicarb values, what will be seen. Bicarb is 32 and PaCO2 values is 8. So what do intervention I am having? PaCO2 values on the higher side. So it is a respiratory acidosis. Along with bicarb has gone on the higher side, but the pH is still on the lower side itself. So it is a partial compensation. So metabolic acidosis with partial metabolic compensation is the right answer here, second one. 19 years old female presents to the ED with complaints of acute onset of shortness of breath, which is not allowing her to carry out her regular activities. Someone who is not allowing to carry out her regular activities, it is a significant symptom what you need to consider. On examination, the vital parameters tachycardia, blood pressure is fine, tachypnea is present, slightly hypoxic. The air entry is reduced on the right side. Chest X-ray shows right-sided pneumothorax. The patient is requesting immediate relief of the symptoms. What is the appropriate step in management? So we will see whether the symptoms are significant or not. Are the symptoms significant? Yes, definitely it is significant. So no significant. Next, we'll go into the column and see whether the patient is unstable or having an chronic lung disease or age is more than 50 years plus significant. Those columns you are seeing, none of those parameters are present here. Those parameters are not present, then we give three options. One is conservative management. Another one is basically ambulatory device, which is not given in the options at all. Another one is needle aspiration. But the patient wants what? Immediate relief of the symptoms. Because the patient wants immediate relief of the symptoms, we'll do needle aspiration. After doing a needle aspiration, if the symptoms still persist, if the patient is still symptomatic or still has significant symptoms, what we are talking about, then you will place an ICD and admit. If the symptoms are reduced, then you can discharge. So the right answer here is needle aspiration. Again, you need to remember here is, yes, that's all you need to remember, and we'll move ahead. A 40 years old male, a known case of HIV, presents with cough and fever for since 3 to 4 days. He denies any other symptoms. He has recently undergone an appendectomy. His observations are completely okay. There's right tachycardia and tachypnea is present with slight hypoxia. X-ray is done. COVID is negative. What is the treatment for this patient? They are asking. HIV patient. On an X-ray, bilateral infiltrates are present, suggestive of a pneumocystitis jirovecii. So this is a pneumocystitis jirovecii. What we are having here. What is the treatment? Cotrimoxazole, also known as trimethoprim and sulfamethoxazole. So the right answer here is the first one. A 19 years old male complains of an pleuritic chest pain with shortness of breath. He is known, no comorbidities are there. Ankle fracture a few days back, which is present. He is on below knee back class. He is on no other medications. Slight amount of tachycardia is present. All of the parameters, slight amount of hypoxia is present. Tropa is negative. CTPA is suggestive of an PE. What is the next best step? Before we go for NPE, we have NTPE diagnosis. We need to see whether it's a stable or unstable. This is a stable patient, what I am having here. Why do I call it as a stable patient? Because I'm just looking at the blood pressure. Systolic blood pressure is more than 90. That is enough. A stable blood pressure patient will be treated with direct oral anticoagulant like apixaban, rivaroxaban. So the right answer here is DOAC, direct oral anticoagulants. A 22 years old male deep sea diver presents to the emergency department with complaints of a mild shortness of breath since a day. He has no comorbidities. Observations follows like this. This looks grossly normal. X-ray shows an pneumothorax of less than 2 centimeters. What is the next best step in the management? Mild breathing difficulty. So conservative management, what we are having. There is nothing suggestive of an secondary spontaneous pneumothorax. So it is an primary spontaneous pneumothorax. Primary spontaneous pneumothorax can be discharged, but you need to advise that no diving and follow-up after 2 to 3 days. So this one is the right answer. Here, discharge, yes, right. Follow-up not after 4 weeks. After 2 to 3 days itself, they need to have a follow-up. Along with, you need to precisely mention that no diving should be done. So the most correct answer here is the second one. A 24 years old female presents to the ED with right-sided pleuritic chest pain. She described it as a sharp pain with words on inspiration. She had no similar complaints in the past. She has no comorbidities. Vital parameters are stable. We decide to use well score for your further clinical management. According to the score, when to get an CTPA done? When do you get an CTPA done? They're asking. When do you get an CTPA done? When the scoring is more than 4. Which is more than 4 here? One of you have seen 2? No, 2 is not more than 4. More than 4, not equal to 4. So the second option is wrong. The first option is the right one. Many got confused with this one. The first option is the right one because it is more than 4, not 4, not equal to 4. More than 4, that is 5 or more. Yes, you get a CTPA done. 4, you do not get a CTPA done. You get an D-dimer done. A 30 years old male present to the ED with complaints of a fever and a cough since 3 to 4 days and no comorbidities. He is an history of unintentional weight loss since couple of months. X-ray is shown below. The vital parameters are given here. What is the most appropriate investigation you will be doing? Further investigations, what you will be doing? Bilateral infiltrates is present. Young adult, he is quite 30 years. Why he has a bilateral infiltrate? You need to strongly suspect, including with the weight loss, you need to strongly suspect this patient might be having an HIV because you're suspecting this to be a pneumocystitis jirovecii. That's why you're strongly suspecting this patient might be having an HIV. So get an HIV test done. Do not think of miliary tuberculosis. It doesn't exist, or it is very, very, very rare in UK. So whenever we are practicing in UK, we do not think of miliary tuberculosis at all. Okay, it might be very common in your country, in especially in Southeast Asia, it might be very common, but do not think from exam point of view. A 60 years old known case of COPD presents with an presence to the emergency department with breathlessness, and these are the vital parameters which are present. ABG is given below. The ABG suggestive of what they are asking. We'll see here pH is on the lower side. Low pH we are having. And PaCO2 is on the higher side. So high PaCO2 values. And bicarb is also on the higher side. So two things we can call it as. We can call it as an respiratory acidosis with partial compensation. Okay, we can call it as an respiratory acidosis with partial compensation. Partial word is missing here. Then what you can do? What else can you call it as? Is it a type 2 respiratory failure? Yes, it is a type 2 respiratory failure. Is it an acute type 2 respiratory failure? Yes, it is an acute type 2 respiratory failure. Is it an chronic? Yes, because the bicarbs are on the higher side, it is a chronic. So acute on chronic type 2 respiratory failure is the most right answer here. The second one is the most right answer. A 66-year-old patient, history of right lobectomy. That means a part of the lung is removed. So if this is the lungs, what you are having here, part of this is cut and removed it off. Okay. Right lobectomy has been done. On Oscar complaints presented to the department, shortness of breath. On examination, there is a reduced air entry. You auscultate, there is a reduced air entry. It might be because of the lobectomy itself or for some pathology. Right-sided tracheal deviation, trachea deviated towards this side. Yes, it does happen because this space is empty because you removed it. So this lung will expand more and might result in trachea deviating to the opposite side. The vital parameters are given. The main striking one is hypoxic in spite of 10 liters of oxygen. So what is happening? We do not know what is happening. To know what is happening, it's better to get an X-ray imaging done and see what is happening. Things what you need to rule out. Can it be a pneumothorax? It cannot be a pneumothorax. Trachea is deviated towards the same side. Though the air entry is reduced, it might be because of lobectomy itself. So you cannot 100% say there is a pneumothorax. There might be a small pneumothorax might be present or moderate pneumothorax size might be present. IV antibiotics, there is nothing suggestive of an infection here. Might be present on an X-ray consolidation, then you can give the IV antibiotics. ICT insertion, you cannot directly jump to insert an ICT because nothing is suggestive of an pneumonia or a pleural effusion in this patient. Blood cultures, good idea if it is a sepsis, but we are not thinking of a sepsis. So knowing what is happening, you need more information. That's why you're getting an X-ray done. A 45 years old patient present to the emergency department with complaints of shortness of breath. Remember this, they are not mentioning the duration. He denies any other symptoms. He's known comorbidities. He has given the vital parameters here. X-ray is given. What is the most probably diagnosis? Okay. This might be happening since a longer time, what we are suspecting here. How to see the X-ray? So everything depends on the X-ray here. X-ray, we are having X-ray is given here. There is a white patch, what you are seeing on the apex region. This is the trachea. So trachea is central. It is not deviated. If this was a lung collapse, it would have deviated on the same side. So lung collapse, I can just rule out and lung collapse here. Pleural effusion, I can rule it out because there is no obstruction of claustrophrenic angle. So I can rule out an claustrophrenic angle. Pneumonia usually presents as a consolidation. Usually it will be in the middle lobe or in the lower lobe, unlikely in the upper lobe. And there is no cavity to call it as a tuberculosis also. So pneumonia, I'll rule it out. Pneumothorax is more appears black in color, not in white in color. I rule it out. So left off is soft tissue mass here. Keeping this in mind, the same question appeared in last diet. With a twist, it had appeared, which we'll be discussing in coming up slides. So keep this in mind. It will help you to answer the other question what we are having. A 39 years old male presented to the emergency department with complaints of cough since 3 to 4 weeks associated with hemoptysis. He is given us a history of recent visit to Afghanistan and long history of cough is present. Okay. And on here X-ray, you can see there is some amount of cavity and upper lobe is involved. Keeping all this in mind, you are thinking of an tuberculosis. So classical history, a long history of cough and travel history with a classical X-ray is tuberculosis for you for exam. So very classical it will give, you will not miss an tuberculosis in the exam. A 28 years old male with no significant past medical history present to the ET complaining of shortness of breath and cough since few days. Also gives an history of a weight loss and loss of appetite since few months. Okay, his observations are as follows. Chest X-ray is given. What is the next best step they are asking? What are you thinking about? Bilateral infiltrates are present. Young chap, and he has a history of weight loss and loss of appetite. Thinking of an HIV, might have predisposed to pneumocystitis jirovecii. So the treatment is cotrimazole. A 37 years old female complaints of chest pain since last couple of days, which is associated with shortness of breath. She denies similar complaints in the past. She has no past medical history or surgical history. LMP was 3 weeks back. The patient is received in the resus bay and connected to the cardiac monitor. The vital parameters, tachycardia is present, hypotension is present. The nurse has taken a 12-lead ECG. And what is the most likely diagnosis? 12-lead ECG. There is a tachycardia which is present, which is the most common finding of an P. But what is more important for us to pick it up? Q3, third lead is this one. Q waves are seen, so Q3 is present. T wave is inverted, so T3 is present. S wave is present in lead 1, so S1 is present. This is much more suggestive of an PE. That's why we are thinking of an PE depending on the ECG finding what they have given. So whenever they give an ECG with a chest pain, think of it might be an PE, especially in the pleuritic chest pain. If they are giving it, think of PE. Look for Q3, T3, S1 pattern. A 46 years old female presents with acute shortness of breath with pleuritic chest pain. She is a known case of hypertension, diabetes, and hyperlipidemia. 6 months back, she was diagnosed with DVT and stopped the warfarin a few days back on doctor's advice. CTPA has been reported as a saddle type of thrombus here. Hypotension is present. What is the next best step? You have a PE diagnosis, unstable patient because systolic blood pressure is less than 90. I want to thrombolyze. Thrombolytic preferred agent is alteplase. You can use other thrombolytic agents like tenecteplase also, but most of the time alteplase which is preferred, or you can use tenecteplase also. You can use it. This doesn't matter. You shouldn't be using it. A 29 years old male, a known case of asthma presents to the ED with increasing shortness of breath and wheezing. He's unable to talk in a single sentence or talk in full sentence. He has been using increasing amount of inhalers since past few days. On examination, there is tachypnea, tachycardia, blood pressure is fine, saturation not less than 92%. What we are having, he has a wide space toward the chest, and ABG is given to you here. What is the severity of the patient? In ABG, I always try to look on an PaCO2 value, which is in the normal range. If it is in the normal range, in spite of in spite of tachypnea, I am thinking of an life-threatening asthma. So this is an life-threatening asthma. Mild asthma. Mild asthma, what you'll be having? He'll be able to complete this in single sentence. So you cannot, this is not at all mild. Confusion should be in acute severe or in life-threatening asthma. All the symptoms are there of acute severe except this one. This should have been on the lower side, but it is in the normal range. So it's often life-threatening asthma. The same thing, I will change it to, for example, 6.8. What it will be? It will be an near fatal asthma. Good. One of you got it right. Good. A 40 years old male, a known case of COPD and a smoker, presents to the ED with worsening of the shortness of breath. You start the patient on salbutamol and ipratropium bromide naps. The patient feels better and the work of breathing is reduced. On examination, there is vitals looks better, but saturation, yeah, vitals kind of better, but still acidosis, some amount of acidosis is there. PaCO2 values are on the same on the higher side. What is the next best step in the management? They are asking. Anyone else want to answer? One of you have answered as one. Yes, you can give theophylline infusion for this patient before jumping into an NIV. So the sequence of treatment is NEPs. What are the NEPs? Salbutamol plus ipratropium bromide, what you are giving. Once you are done with this, give an IV drug. Only one IV drug is given in COPD patient, that is theophylline. In spite of, this is the medical management. In spite of medical management, patient is not improving. Has one of these factors, what I'm mentioning or writing down here, then you basically go ahead and start on the NIV. This is the indication to go ahead with an NIV. Though these parameters are present in this patient, we are not done a complete medical management, which is theophylline. So start on theophylline. A 60 years old female present to the ED department with complaints of sudden onset of shortness of breath since morning. She has a recent history of ankle fracture, is on and leg cast for the same. She has no significant comorbidities, has not undergone any surgeries. Her observations includes a tachycardia. Okay, tachypnea is not important for me. Keeping all this in mind, what is the well score? What they are asking, or what is the most appropriate approach? For that, we need an well score. What is the well score of this patient? P is the most likely diagnosis, so I'll give it 3 here. Immobilization is present, that carries 1.5 marks. Tachycardia is present, that again carries 1.5. Total is 6. Anything more than 4, you will directly go ahead and get an CTPA done. So the right answer here is CTPA. A 45 years old female, a known case of asthma, brought to the ED in the ambulance. She is complaining of worsening of shortness of breath. She denies any fever or chest pain. She is not able to carry out her regular activities because of her breathlessness. Which one of the following is suggestive of an life-threatening asthma? In this life-threatening asthma, there are 2 correct answers. Life-threatening asthma, any SpO2 values less than 92 is a life-threatening asthma. Yes. Hypotension or cardiac arrhythmias, life-threatening asthma. Yes. Both 2 and 3 are the right answer. Okay, what we are suspecting, usually this can happen. Okay, in exams, there might be more than one correct answer. Usually they will delete this question. So no one gets any marks. They delete it off, and out of 180, it becomes 179. So few of the questions get deleted for this particular reason in the exams, where they might have thought something, or there might be a typing error, and eventually they realize it. So eventually they remove it later on the question itself. So both SpO2 and hypotension is the right answer here. A 66 years old, oh, sorry, there. Okay, there are the explanations also written here, but anyways, we'll discuss here. 66 years old presents with severe shortness of breath to emergency department. His oxygen saturation is on the lower side, and he has decided to intubate the patient. After intubation, the oxygen saturation is not improving. A bedside X-ray has been taken. A white shadow over the right apex is seen as shown in here in the X-ray. What's the most likely cause? What are we suspecting here? In spite of intubation, it is saturations are not improving. Something has happened acutely. Okay, this is an acute condition. What do you need to pick it up? Which one of the following is the acute condition what you are having? ET tube. ET tube cannot be visualized to say it is in right main bronchus. I need to withdraw it. So this is not the right answer. Soft tissue mass is a chronic condition as explained. Hyperinflated lungs appears black in color, not in white in color. You rule it out. Aspirational pneumonia can be one of the diagnoses, but X-ray findings takes time. It takes days together to develop. It doesn't develop immediately. That's why the most appropriate answer is right upper lobe collapse in this patient. So the first one is the right answer. They have changed a little bit. It was a similar kind of X-ray, but the diagnosis changed depending on the presentation what they had. So be aware of it. A 64 years old female is brought to the emergency department with worsening shortness of breath, and she is a known case of COPD. Upon further questioning, she reports coughing up yellowish color sputum and fever. On examination, she is febrile and has a saturation of 87% on the room air. According to the NICE guidelines, which one of the following is an indication for hospital admission? Most of them went ahead and picked up a raised POCO2 values on ABG, which can be seen It's not an indication. Okay, anyone COPD can have an rest PaCO2 values without any acute exacerbation at all. So it is not. Increased sputum value, again, not. Oxygen saturation or known oxygen sensitivity, no. Repeated antibiotic, no. It is not mentioned in the indications what I have taught you guys. But worsening of the pedal edema, yes, that is there. So the right answer is the fifth one. Uh, sorry, an elderly male with known history of COPD presents to the ED department with worsening symptoms. He reports that his shortness of breath has become increasingly severe and he's struggling to manage at home. He was treated for similar symptoms with an chest drain 1 week ago. His vitals are as follows. A chest X-ray showing pleural and pneumothorax is provided, was given. I couldn't find it on internet. That's why I've written the findings. There was an effusion along with a pneumothorax as present. What is the most appropriate management plan? What you'll be doing for this patient? You need to place an ICD for this patient. Okay, because it is in secondary pneumothorax what I'm having, there is an effusion which is present. Whenever the effusion is present and I told you symptomatic, then you will go ahead and intervene. I'm saying it is significantly symptomatic because of low saturation. So you need to place an ICD. You need to place an ICD, whether a small size or a large size one. You need to place a large size ICD, not a small size ICD. The reason for the large size is because of the pleural effusion. In a small size ICD, the pleural effusion cannot be drained. Only air can be drained. That's why open technique of placing a chest drain needs to be followed. Seldingham's technique, if you use it, you can place only a smaller size. So the right answer here is placing an open chest drain. Okay, that what you need to remember. A 76 years old male present to the ED with a 1 month history of dry cough for which he has not sought any medical attention. Earlier today, he has an episode of coughing during which he had produced 2 to 3 ml of blood, prompting him to come to the emergency department out of the concern. His vitals are stable. X-rays performed shown below. What is long form of ICD? Intercostal chest drain. Chest drain is the same thing. Open is the technique name. Okay. Open chest drain. So open technique you're using to place and chest drain. So here in the X-ray, what we are saying here is that was the answer for the question which was typed, was asking about an open chest drain versus ICD in is the same or not. Okay, coming back to the question what we are having here. What we are having here, this is classically known as coin lesion. Whenever you are having an coin lesion, you need to always suspect it can be an cancer. This patient had an hemoptysis of 2 to 3 ml. That is fine. That is a negligible amount. He's completely stable otherwise. Okay, elderly person having a coin lesion, think of an CA. This patient requires an CT scan done to get a better understanding of the lesion, what is present there. Now the question comes is whether to get a CT scan done immediately or to get a CT scan done later on outpatient basis. It is a cancer what you're thinking. If there is a delay by 1 month, nothing will happen. So an outpatient, immediately you will get it done only if the patient requires an immediate CT scan done. So an outpatient CT scan can be done within a week or 2 weeks of time. You can get it done. It doesn't require to be done immediately. This is a coin lesion, which is suggestive of a cancer. Next one we are having is a 29 years old male known to be an intravenous IV drug abuser, presents to the ED with 3 to 5 days, denies any other symptoms, no similar complaints. So IV drug abuser, what you need to be aware of, bilateral infiltrates is present. You are again thinking of pneumocystitis, Girovecchi here. The treatment is cotrimazole. Also, you are giving trimethoprim and sulfamethoxazole. Again, repeat question. That's why we're not repeating there. And we are going with the next one. A 68 years old male present to the ED with complaints of swelling of the entire right-sided lower limb associated with pain. 3 days back, he underwent a total hip replacement surgery. He's a known case of gout, hypertension, rheumatoid arthritis, was previously diagnosed with a left lower limb DVT for which he was given warfarin for 6 months. On examination, is stable. The nurse informs you that Doppler scan is not available for next 24 hours. What is the most appropriate next step? What we have thought here, if you do an well score, it will be more than one, obviously, because the entire lower limb is swollen, which will get 1 point here, previous surgery 1 point, previous DVT 1 point. So totally 3 point on the well score. You need to go ahead usually with an USG scan that is nothing but Doppler scan done. But the problem here is nurse says Doppler scan is not immediately available. What you'll do? The recommendation is you get an D-dimer and start on interim treatment, that is low molecular interim treatment of anticoagulants. What you need to start on? So you'll be starting on anticoagulants. Preferred one is direct oral anticoagulant. All right. Out of this, which one is important to be started immediately? Starting anticoagulants is immediate, followed by D-dimer. A delay in D-dimer results will not affect the management plan. That's why you are starting with the low molecular weight heparin first. Wait for the Doppler scan without starting the interim treatment is not the right approach. D-dimer has to be got it done after you start them on the interim treatment. Okay, low molecular weight heparin can be given as an alternative to direct oral anticoagulant, that is rivaroxaban and apixaban. Discharge and advise, absolutely not. Admit for further evaluation. You need to get a Doppler scan done. Before that, next step they are asking. This is further management. Yes. Admitting yes. That's why. Direct oral anticoagulants is the preferred one. Option is not given. So the most appropriate answer, you're picking it up. Okay, low molecular weight heparin can be used in a 68 years old. Next best option. So always remember that the most correct answer, you're picking it up, not the exactly the guideline. The like guideline they may not be giving. They might differ a little bit and play you around. So they might be two right answers like here. Most right answer which is there, most correct one which is there, what you'll be picking it up. So that finishes the recalls, including the last dad's recalls questions we have completed here. Anyone has any questions, you can ask me. Anyone, any questions? If you want, you can unmute and ask me before we end the class here.